workshop, and I'm Dr. Moise. I'm pulmonologist with the team. Apologies for the delay. We were waiting because it's an election day. We were waiting in the interest of the registered delegates, would not find traveling resources. So for inaugural, I would like to invite Sandeep sir, Vijay sir, and Harish sir, uh, who is medical director at Mount Sinai Hospital in New York, and who has done uh, his work extensively in lung transplantation. Please come on to the dais. Now I would request Sandeep sir to give an introduction speech.
Good morning, everybody. Thank you for coming. It's a great pleasure to invite Harish here back again among us. For most of us who've been in this room long enough and been with the service, I don't think we could ever forget his contribution and his motivation for us to uh, look at doing something in the arena of lung transplantation. Harish has been an individual who never sits on the fence. He has very clear opinions and ideas about the fundamentals of end-stage lung disease and lung transplantation. Just to go back in time, it was late 2016, early 2017 that he and a bunch of his colleagues, some of them his trainees, who then became his colleagues, and I would now call them peers, inspired us to set things right in our practice, especially in the area of lung transplantation. He has continued to show us new light every time that he interacts with us. It's truly a great pleasure and an honor for us to have him here. I am sure he will undoubtedly kindle the same flame in every one of you today. Uh, when Harish walks into the room and he takes on the dais, a podium, everyone is changed forever. Harish, thank you very much for coming here. It's truly an honor. And for every one of you in the field, I guess your interest is clear by your presence in this room. I can assure you this is going to be a fascinating day of great insights into lung transplantation. Thank you everyone for coming.
Yeah, so to begin with, For the day, we have 7 lectures in the morning session, followed by workshop hands-on things in the post-lunch section. So during the 7 lectures, each will be around 30 minutes, and we have divided 20 minutes for the talk, and 10 minutes will be the case discussion kind of scenarios. So to begin our journey, first we should know when the lung transplantation journey of our patient should start. So first talk by me will be on the recipient selection and indications of lung transplantation. So over the next 30 minutes, I'll summarize the guidelines by the International Society of Heart and Lung Transplantation, and which also has contribution from Sandeep sir. He had contributed it majorly in the guidelines formation. So the lung transplantation basically was first performed in 1963 by James Hardy at University of Mississippi, and the recipient survived only 18 days. And when the doctors went back and tried to know what the cause was for the early mortality, it was primarily renal failure and malnutrition, which was because there was no immunosuppression regimens designed at that time. So you can clearly see that the immunosuppression post-transplant is the most important aspect, which maintains the graft function and quality of life. So for the next 2 decades, there was almost no further development in the field. Finally, in 1981, combined heart and lung transplantation was performed by RITS at Stanford University for idiopathic pulmonary arterial hypertension. And according to current guidelines, idiopathic pulmonary hypertension does not warrant combined heart-lung transplantation unless RV is very much dysfunctional. Then in 1983, single lung transplantation was performed for IPF by Joel Cooper at Toronto General Hospital. Following in 1986, first double lung transplantation for emphysema was performed by Vaughan at Duke University. Then we go on to the recipient selection and indications. So first of all, I'll just show you the general indications, and then we'll deal with the disease-specific indications. And in disease-specific indication, we'll see the timing of referral and timing for the listing. So by the term timing of referral, I mean to say when the patient needs to be referred to a transplant center where a detailed evaluation needs to be performed, and following which it will be the decision of the transplant team when to make him active on the recipient list. So coming on to general indications, there should be clinically and physiologically advanced lung disease for which medical therapy should be ineffective or unavailable. Yeah. Then it should be a high risk, more than like 50% risk of death if we don't do lung transplantation in such cases. And then it will be like a high likelihood of surviving at least for the 5 years post lung transplantation. So just to show you it graphically, there's a graph which shows the spectrum of a end-stage lung disease. So you can see that there is a plateau which slowly goes down. And if we refer in that scenario, it will be too early, and there is a small window which is being highlighted by the pink color there, which we call it as a transplant window, where we should do transplant. And further to it is late transplantation. It will be too late. And in our experience of around 500 lung transplantation, most of the patients what we look at are too late. So just for your knowledge, in this month we have done 4 ECMO bridge to lung transplantation, which I would say they are like very much high risk cases, which carries high post-operative mortality and morbidity. So we need to be very much proactive in referring to the cases, and we should refer the case when they are fit for lung transplantation. Then we go on to disease-specific indications. For COPD, timing of referral should be like board score of 5 to 6, who is having frequent exacerbations. And if there is increase in board score of 1 over past 24 months, who is developing PAH, FEV1 20 to 25% of the predicted, clinical deterioration despite maximal therapy like bronchodilators and pulmonary rehab, oxygen support, nocturnal non-invasive positive pressures, poor quality of life which is unacceptable to the patient, And for those candidates, like now is the era of minimally invasive lung surgeries and bronchoscopic interventions. In such scenarios, when you refer the case for LVR, at the same time, you also need to refer the case for lung transplant evaluation. Then coming to timing of listing, board score of 7 to 8, and the additional risk factors that may prompt listing include FEV1 less than 20% of the predicted, presence of moderate to severe pulmonary hypertension, history of severe exacerbations, and chronic hypercapnia. Then we go on to interstitial lung diseases. So timing of referral in interstitial lung disease, if you see a UIP pattern on the CT scan, you need not wait for FEV1 to drop. You need to directly refer the case to a lung transplant center. So in other cases, who has pulmonary fibrosis with FVC less than 80% of the predicted or DLCO less than 40% of the predicted, pulmonary fibrosis with one of the following in the past 2 years, there is a relative decline in FVC of 10%, a relative decline in DLCO by 15%, relative decline in FVC in combination with worsening of respiratory symptoms and radiographic progression. By this, we mean there is an increase in oxygen requirement of the patient, requiring oxygen support either at rest or on exertion. And for patients with CTD or with family history of ILD, you may consider early referrals. Then coming to timing of listing, any form of pulmonary fibrosis with one of the following in past 6 months despite appropriate therapy, which includes absolute decline in FVC of more than 10%, absolute decline in DLC of more than 10, absolute decline in FVC of more than 5% with radiographic progression, desaturation on 6-minute walk test to less than 88%, or more than 50 meters decline in 6-minute walk distance over the past 6 months, and pulmonary hypertension on right heart catheterization or 2D echocardiography. History of hospitalizations because of exacerbations, pneumothorax. Then we go on to bronchiectasis, which may be because of cystic fibrosis or non-cystic fibrosis. In our experience, we have seen more of pulmonary tuberculosis sequelae leading to bronchiectasis, ABPA bronchiectasis. Cystic fibrosis also we have seen, but we have seen 2 cases of cystic fibrosis. So in them, timing of referral is, if it is a case of cystic fibrosis, medical therapy with a trial of elexacaftor, tezacaftor, or ivacaftor if eligible. If FEV1 is less than 30% of the predicted in adults or less than 40% predicted in children, FEV1 of less than 40% predicted or less than 50% in children with any of the following, like 6-minute walk distance less than 400 meters, patient developing type 2 respiratory failure with CO2s more than 50 mmHg, hypoxemia at rest or on exertion, pulmonary hypertension, worsening nutritional status, 2 exacerbations per year requiring intravenous antibiotics, massive hemoptysis requiring bronchial arterial embolization, and more than 2 pneumothorax and FEV1 less than 50% predicted, and there is a rapid decline in the PFT values. Exacerbation requiring NIV or invasive mechanical ventilatory support. So then we go on to timing of listing. FEV1s less than 20%, 25% predicted. Rapid decline in lung function or progressive symptoms, more than 30% decline, relative decline in FEV1 over the 1 year time. Frequent hospitalizations, more than 28 days of hospitalization would need listing. Any exacerbation requiring mechanical ventilation, chronic respiratory failure, pulmonary hypertension with evidence of right ventricular dysfunction, worsening nutritional status with BMI less than 18, which can be because of the loop which they get stuck in, like infection and again. Recurrent massive hemoptysis despite embolization. Then we go on to the next indication of lung transplantation, that is pulmonary hypertension. In them, timing of referral includes ERS or ECS intermediate or high risk or reveal risk score of 8 despite appropriate PH therapy, significant RV dysfunction, need for IV or subcutaneous prostacyclin therapy, progressive disease despite appropriate therapy, recent hospitalization for worsening PH, known or suspected high risk variants such as veno-occlusive disease, capillary hemangiomatosis, scleroderma, large and progressive pulmonary artery aneurysms, signs of secondary liver or kidney dysfunction due to right heart dysfunction, and potentially life-threatening complications such as recurrent hemoptysis. Then timing of listing would include a reveal score of more than 10 on appropriate pH therapy, including IV and subcutaneous prostacyclin analogs. Progressive hypoxia, especially in patients with PVOD and PCH. Progressive but not end-stage liver or kidney dysfunction due to PAH. Life-threatening hemoptysis. Then we go on to cystic lung disease, lymphangioliomatosis, uh, which is relatively a rare indication of lung transplantation. Fewer patients require lung transplantation with the development of standardized mTOR inhibitors as treatment. It remains an indication for those whose lung function is severely abnormal, like FEV1 less than 30%, exertional dyspnea, hypoxemia at rest, pulmonary hypertension, and refractive pneumothorax. In them, evidence of disease progression despite mTOR therapy, usually with sirolimus or everolimus. Everolimus is the preferable drug because it has short half-life and at low therapeutic levels can be maintained at the time of listing. So mTOR inhibitor can be continued till the time of transplantation and they don't interfere with the healing of the anastomosis. They are challenging cases surgically because of recurrent pneumothoraces. They would develop pleural adhesions and intraoperatively they may bleed more. Then we go on to thoracic malignancies, which is again a very rare indication of lung transplantation. Less than 0.1% of all the lung transplants performed worldwide are for malignancies. It should be limited to very selected cases of lung transplantations of adenocarcinoma in situ or minimally invasive adenocarcinoma. This is just a HPE of adenocarcinoma in situ. And lipidic predominant adenocarcinoma, in whom surgical resection is not feasible either because of the multifocal disease within the lung or medical oncology therapies have failed or are contraindicated, and lung transplantation is considered to be curative in such cases. Then we come on to the acute respiratory distress syndrome. The factors that favor short-term and long-term better survival in ARDS includes young age, lack of comorbidities, lack of extrapulmonary organ dysfunction. Yeah. Use of ECMO as a bridge to lung transplantation. ICU acquired muscle weakness should be less and active rehab should be done. Sorry for that. ICU acquired muscle weakness. Recommended waiting period for any case of ARDS would be 4 to 6 weeks, and then on only we should pursue the option of lung transplantation in them. So that finishes our disease-specific indication, and then we go on to contraindications. Absolute contraindications would be like lack of willingness of the patient for transplantation, malignancy with high risk of recurrence or death related to cancer. It is advisable usually to wait for 3 years for a disease-free survival, then only consider them for lung transplant referral and listing. GFR less than 40 ml per minute. Acute coronary syndrome or MIs within 30 days. Stroke within 30 days. Any other end organ dysfunction like cirrhosis of the liver and portal hypertension. Acute liver failure. Acute renal failure with raising creatinine or anuria. Any patient in septic shock. Any extrapulmonary disseminated infection. And active tuberculosis, of course. And limited functional status with poor potential for post-transplant rehab, progressive cognitive impairment, and related episodes of non-adherence, because post-transplant patient will be on a lot of medications which needs to be taken on time to have better outcomes. So adherence is a very important factor which we consider when we are evaluating the patient. So any active substance use or dependency like tobacco use, vaping, marijuana, smoking, or IV drug use, and other uncontrolled medical conditions which will limit the survival post-transplant. Then we go on to high or substantially increased risks, which include age more than 70 years, uh, severe coronary artery disease that required bypass during transplant, a reduced ejection fraction that is less than 80%, 40%, significant cerebrovascular disease, severe esophageal dysmotility, which will predispose the patient to GERD and risk of aspiration, which is again a risk factor for early CLAD, that is chronic lung allograft dysfunction. So untreatable hematologic disorders like bleeding diathesis, thrombophilia, or severe bone marrow dysfunction, BMI more than 35 or BMI less than 16 would be a high risk case to consider. Limited functional status with potential for post-transplant rehab. Any psychiatric disorder again will put the patient on high risk. And care and support system, which also plays an important part post-transplant, needs to be considered. A lack of understanding of disease and/or transplant despite teaching. So Mycobacterium abscessus infection, Burkholderia infection, any hepatitis B or C infection with detectable viral load and liver fibrosis, chest wall or any spinal deformity expected to cause restriction after transplant, any extracorporeal life support, any retransplantation 1 year following initial lung transplant, retransplant for restrictive CLAD, and retransplant for AMR as an etiology of CLAD will put them on very high risk. Then we come on to unfavorable risk factors like age more than 65 to 70 years, GFR in the range of 40 to 60, mild to moderate coronary artery disease, severe coronary artery disease that can be revascularized via percutaneous coronary intervention prior to transplant, or CABG during the transplant itself, and low EF. In such cases, postoperatively, the most commonly we encounter arrhythmias, uh, atrial fibrillation being the most common one. Any peripheral vascular disease, connective tissue disease with scleroderma, lupus, inflammatory myopathies, severe GERD, esophagus dysmotility, and any again thrombocytopenia, leukopenia, or anemia with high likelihood of persistent after lung transplantation. So this slide summarize basically the indications and contraindications. Then we'll go on to case discussion part, and I would like to invite Harish sir, Vijay sir, Unmil sir, and Pawan sir onto the dais to moderate the case discussion. So here I'll be presenting one of the challenging cases we came across. So basically, she was a 52-year-old female, known case of connective tissue disorder (ILD) on continuous oxygen support. And during pre-lung transplantation evaluation, we found that she was HLA sensitized, which we usually do with PRA. Which showed class 1 positivity of 58%. Anything more than 30% is considered to be a high risk factor, and HLA class 2 being less than 10%. So the team unanimously decided to plan a desensitization for this female with IVIG and plasmapheresis. So the risk factors for HLA sensitization include pregnancies. In this female's case, she was gravida 4, 3 para, and 1 she had abortion. Maybe that predisposed her to HLA sensitization. Any connective tissue disorder, history of blood transfusions, prior organ transplantation, and ECMO support prior to lung transplantation. So in the December 2021, first cycle of plasmapheresis with IVIG was done, and subsequently we did second and third cycles. And during the plasmapheresis, she started developing type 2 respiratory failure, hence was supported with an IV. And another challenge which we faced in this case was like 2 days after the third cycle of plasmapheresis, she had weakness of the right upper limb and lower limb. CT brain showed acute infarct, and subsequently she was started on low molecular weight heparin and antiplatelet drugs. And because she had two risk factors of being HLA sensitized and having a neuro issue, so we kept her inactive on the organ recipient list, and we started neuro and pulmo rehab for her. And adequate nutrition was provided to her. Bedside chest physiotherapy and mobilization was ensured. And over the next 8 to 12 weeks, she improved neurologically and she was able to walk without support. Uh, and hence, again, SABs were repeated, and this is a representative image, not per se of her. So in her case also, the SABs like were in MFIs were in the range of like 15,000. So she was still sensitized, and in view of this, we planned further desensitization with 2 cycles of IVIG plasmapheresis, and she was also given bortezomib to which is a proteasome inhibitor, which basically acts at B cell level, inhibiting the further antibody productions. So, following which she was again activated on list. And in view of positive PRA, a prospective cross match was done with the donor. Uh, Prospective cross match can be done by two methods basically. It can be complemented directed cytotoxicity test, and another would be HLA Luminex based assay. And in her case, it was negative, and we proceeded with lung transplantation. And intraoperatively, 1 cycle of plasmapheresis was given, and following which, on second day, POD2, one more plasmapheresis was done, and on POD4, she was extubated successfully, and she's almost 1.5 years post transplant, and she's doing well with no AMR or CLAD. That ends my presentation. Thank you.
I think it's a great case. Congratulations. I mean, it's a journey. The 5 points I want to make here is the team effort it takes for a patient to be evaluated, listed, making sure the patient remains a viable candidate to transplant, and the pitfalls and the challenges one would face: stroke, CPRAs, and then maybe an infection. And you were not deterred by these events and persisted on her care. Uh, Rightfully, you waited for the plasma exchange to work, and your prospective cross match was negative, proceeded with transplant. So, well orchestrated, challenging case, I agree, and congrats to the team. Three caveats there are CPRAs are real, so giving blood products and during the management of an advanced lung failure, sorry. So avoiding transfusions and live vaccine immunizations are real, and they can bump your PRA acutely, so that should be avoided.
Right.
And timing of transplant. And the therapies you use should not to decrease the CPRAs, or mitigating the risk that you're dealing with should not be compromising the candidacy for transplant. So this brings about a comprehensive team driving the care, making sure transplant is still viable for that patient, and the outcomes are fantastic, as you did.
Yeah, I would like to comment specifically for the Indian scenario. Ideally, we should be referred early when the patient is on oxygen but is able to be able to undergo some sort of a rehab. Means she at least able to walk, in the room with oxygen. So in our case, almost 30 to 40% of our referrals come when patients are on either a ventilator or admitted with a ILD exacerbation, which is not improving. So that puts a huge strain on the transplant center first to keep these patients alive till transplant. So frequently they go on ECMO to prevent other end organ damage. The more they are on ventilator with the ILD exacerbation, they will need more ionodrop supports. Frequently, they get AKIs and kidney damage, and then they miss transplant or they become too high risk kind of thing. So early referral is very key. It allows the center to optimize the patient, do rehab, check for PRAs and sensitizations, and then deal with it. And so an experienced center can deal with it, but if you have a new center, probably focusing on regular patients, and then as you get more experience dealing with it, you can take challenging cases like these. So as Dr. Harish mentioned, team effort is very important. Even if you may have challenges like even a stroke or significant coronary disease, those things can be managed. We can offer transplant with CABG, or patient can undergo a stent. Then if they can wait for 4 weeks or 6 weeks, then we can undergo transplant after that. Otherwise, transplant with CABG is possible, even though it's higher risk. So this is not the other contraindications like infections, unless it's very active and it's systemic with multi-organ issues. Most of these, if they are lung-centric, like in ARDS patients, once the lung is out, most of the time they will have a good outcome after transplant. So the ARDS indication has really come forward after the COVID pandemic. So we had a lot of patients coming in with ECMOs, with the lung not likely to recover, waited for 4-6 weeks, no improvement, waves of infections. So transplant might be the only way out for these patients. So the team effort is important, the persistence, optimization, all these are very important as far as recipient selection is concerned. Thank you.
One more important point pertaining to this case, like how do we approach a sensitized patient in a lung transplant setting? So there are a variety of protocols which have been published, combinations of either Plex with IVIG plus rituximab, maybe Plex IVIG plus bortezomib. I think there are a variety of centers, and I think each center has its own different protocol depending upon what settings we are dealing with. Specifically from the Indian settings point of view, rituximab is slightly more potent to invite more infection risk. So I think our protocol has been to use Plex IVIG plus bortezomib depending upon the situations. And pertaining to this case specifically, if you see, this was more of class 1 sensitization than class 2. Yeah. And even if you see the SAB, single antigen bead also, it was predominantly DR, not DQ. Right. So I think she was lucky enough to not have a DQ, and that's why I think she's doing well as far as no AMR rejections 1.5 years post-transplant. And second point important is induction is very important here. So when you have a sensitized patient, always the protocol has been to use induction immunosuppression. Commonly used is Simulect. So I think it is very important that induction is given in sensitized patients. Yes, she was on a prolonged hospital stay, which would always increase the risk for infections, but still induction definitely is the way ahead when you have sensitized patients. Thank you.
Thanks, Unma. So regarding the indication for patients who had severe ARDS and subsequent severe extensive lung fibrosis, I think we had one case at Astar who was on ECMO for about 76 days and subsequently underwent a lung transplant successfully. So that was our experience. And regarding the cross match, we do have a little bit of challenges. Now there are new centers or new zones which are coming up across the country. Especially in Karnataka region, we have a new zone called as Mysore zone. So the newer labs are a little reluctant to introduce this, and cross matches across the different labs are a little different, and difficult to interpret in certain times, and also get the results within the time speculated time is a little bit of a challenge. I think that's my experience.
Yeah. Anybody from the audience, if they have questions to ask.
So with IV with chemotherapy, these patients who have drains, they stay for a prolonged with a prolonged drain. How do you manage these patients for transplant? Because they have to, because there are risk of infection. Then again, they are on drain. Should we attempt surgery before that, or we make them wait for transplant?
Great question. It could apply to any advanced lung disease, and most of the advanced lung patients have an infected airway as a risk of seeding. There is no single right answer. This is how we would approach, but generally, uh, if it is a leak that can easily be fixed with minimal intervention, like a mechanical pleurodesis, we would prefer to do that because you cannot time the organ transplant in the next few weeks. You cannot be keeping the patient in the hospital too. So we would prefer to do that. I'm sure there are endoscopic interventions available, and I'm sure they have been tried depending on the centers where one works. For BPF, definitely endoscopic interventions would be preferred over surgical procedures. If you are resorting to surgery, then not using TAL would be the gold standard for transplant, unless there are other thoracic surgeons and they can comment too.
Yeah, we prefer to manage the leak endoscopically. We use spigots, glues, if the leak is too much. Uh, if they are able to maintain with a small leak, we will just keep that and then go ahead with the transplant. We generally try to avoid pleurodesis because of the technical issues and increased risk of bleeding post-transplant. And we deal with it with a, give sufficient time for dissection. We use a laser to when we peel off the lung so that the bleeding is less. I mean the APCs. So there are surgical techniques. I think Dr. Sandeep can elaborate on that. But generally, we will try to avoid pleurodesis in these patients. We try to manage endoscopically, and we had good success with that.
I had a question for Harish. Um, Harish, we have this case above. We've had similar cases in the past, and Vijay might be able to probably elaborate a little more. We continue to do preoperative plex. We face increasing risk of strokes in some of these patients. If I remember correctly, I think we probably lost a couple of them too, ones who were sensitized. And we tried to desensitize them before surgery, which, as you know, is a big challenge. And I would like you to bring that across to the audience. And Pawan, also wanted to ask you your experience during COVID when you used to put chest tubes, and almost invariably every patient would bleed. With specific relevance to Rohit's question, could you both elaborate on these issues?
Strokes with plasma exchange, I think the risk of having strokes is more with the IVIG infusions and the hyperviscosity rather than plasma exchange. We rarely had any plex related strokes, number one. Uh, the second aspect of that is uh, plasma exchange and the timing of transplant. One would probably do the chemotherapies before plasma exchange and decrease the dosage of IVIG to decrease the stroke risk. Use a antiplatelet agent, soft antiplatelet agent to prevent stroke, and slow the infusion rate of the IVIG, the product of the IVIG you're using, and make sure that product is not a product with high viscosity and hyperosmolar concentration.
Harish, what if you continue to be positive? You know, you're
That's a great question. I wish somebody asked. Yeah, you were lucky. Class 1, as Unmil said, this patient had no DQs, which are hard to get rid of. Um, Carfilzomab as an agent gives the maximum buck for the reduction in CPRAs, especially class 2s. Our experience is 40% of the patients get to transplant, 60% of the patients which see a reduction of CPRAs to transplant, less than 20%, and 40% you can't do much. IL-6 inhibitor usage has resulted in dramatic decrements in the um, antibodies temporarily, and IVIG and IL-6 inhibitor Q monthly. I think that would be the way to go moving forward, but aggressive B cell therapies before resorting to these IVIGs, and reserve plasma exchange for the peri-transplant phase. DQs will rebound with plasma exchange, so you want to avoid that until transplant phase.
How long do you keep continuing IVIG? Is it the titer that you go by, or is there some other?
So I think three monthly infusions are minimum to see a good benefit with class 2s, minimum 3. So if you have a patient whom you can keep it from 3 months before transplant, then that would be the way to go.
Does chasing the MFI values really help? I mean, it's like the MFI values keep, changing when we keep doing it. So does that really help chasing those MFIs when the graft is doing well?
The MFI value, why we are seeing in Luminex is the traditional understanding is if you have an MFI more than 4 or 5,000, your CDC is positive. That's why you want to chase the MFI. But Luminex single antigen bead assay, they are all man-made antigens and they may not be fixing complement. Adriana Zevil comes with the C4D assay and C1Q assay, sorry, and of the antibody. And that will tell you whether you have a complement fixing or not. To minimize all this extra testing, a simple lab can do this. Take the patient's serum, pick any lymphocyte across the antigen that you are interested in of a proxy donor, run a CDC crossmatch. If it stays positive, then it's fixing complement. Don't worry about MFI. Don't worry about anything else. So that should be your endpoint. Just do a cross match on a live antigen and keep chasing that. The MFIs can fluctuate, but it may not translate into real clinical benefit.
One extension to that question, I don't know whether it's even a plausible option. Is extracorporeal photopheresis an option for these patients with resistant treatment?
I'm not aware. I don't know.
Pavan, the question was for you for the chest tube bleeds and
Okay. So yeah, two parts. So regarding the air leak, so when the patient is on a positive pressure ventilation, so obviously there's going to be a continuous leak, and when the lung is compromised with an advanced lung disease, we need to make sure as much of the functional lung is available for ventilation as possible. So bronchoscopically, we would use a smaller scope and go to the distal bronchi as much as possible, occlude the bronchi and try to isolate the segment which is leaking. That is one. Once that is done with balloon occlusion or methylene blue, then we would put a glue or a spigot, as Dr. Vijay was telling. And with that, if the leak stops, then the lung expands. That's the best, and we would leave it at that. Second was during COVID, patients on ECMO, requiring ICDs. Yes, the bleed was a major challenge there, and we had to reduce the ACD requirements, and that was a major challenge. And that also whether to put the ICD up front or to wait, and also to see whether it is a smaller leak which would subside. These are the major challenges, because on ECMO, on anticoagulation, if the bleed starts, it used to be continuous bleed, and it used to always be a very difficult situation. And and it's always a challenge. Not only the ICD per se, any, for example, tracheostomy bleed, retroperitoneal bleeds, any of those bleeds are definitely a challenge to manage.
And one more question in the interest of the audience. How would you look at rehabilitation for patients on ECMO? And what is the impact of rehabilitation on faster recovery after a successful double lung transplant?
Yeah, I think in this case we learned a lot from COVID pandemic, because most of the time these patients, they received a lot of IV sedation, paralytics, steroids, colistins. So this was like most of the patients couldn't even lift a finger when they came. So the moment they get shifted here, we stop all the paralytics. We let the patient wake up and then start aggressive rehab. So we had the Motomed machine, which has really changed our management. So even while so the key is to stop all paralytics, all try to reduce their steroids, and then start aggressive mobilization on ECMO, awake ECMO, and improving the mobility is key for transplant success after that. If we have to give it some time, and it will slowly recover uh, functions, so that at least they can be considered as transplant candidates.
Yeah, one question.
Yeah.
In cases of COPD, how this volume reduction surgery helps before referring the patient for lung transplant? Basically surgical, yeah.
At least that's what the data shows. The only intervention in a patient with COPD, we are talking about emphysema, that offers survival benefit is the low risk FE1 more than 20, DLCO more than 20, upper lobe predominant. That is the best intervention for those patients. And if it didn't work, then they could be referred for transplant. As you are all aware, endoscopic volume reduction is up on the front, even in non-upper lobe predominant emphysema, and it has showed improvement in walk test, but not in survival. The only surgical intervention that has shown survival benefit in COPD emphysema is in the volume reduction surgery. But that won't work in patients with pulmonary hypertension, which I mean a PA mean of more than 25 on a right heart cath, even though their right ventricle is normal on the echocardiogram. So normally we would do a right heart cath before determining if they're going for LVRS or not. And a left, because you're opening the chest, you can fix coronary disease if there is any.
Sir,
But to add to his question, in ILD, advanced ILD, you put a glue or something, you lose a segment or a lobe, and the guys may get hypoxic. So if the person is alive on 3-4 liters, and you are taking out a lobe, they may get more hypoxic. That's a risk. So VATS that may be preferred in that group to try to isolate a little area and close it.
sir, is pleurodesis a contraindication for lung transplant?
Which pleural? No, it's not. But if you send me a patient with talc pleurodesis, we will not do it.
Sir, I couldn't understand what is the reason, because we remove a lung which is diseased. So even if it tears while
Hey, that should be the question to your surgeon. I'm a pulmonologist, but The surgeons, if they are okay doing it, that's fine, we can do it. Because you should weigh the risk of who you are sending. If you are spending 4 hours in taking out your pneumonectomy, in just doing the recipient pneumonectomy, you're taking 4 hours. You may stand losing the patient doing that pneumonectomy. Do you really want to risk that in the one life-saving intervention the patient may have for a future life?
Because this commonly happens. We have a patient who is ILD, advanced ILD. He gets a pneumothorax. Patient is far from a place which is far from lung transplant center. So we go for a pleurodis. Then the patient can be counseled, or he arranges finances and goes for a transplant.
If you want to do pleurodesis, avoid talc. That's what I could say. You can resort to any other mode, but avoid talc. But I would strongly encourage you to see a surgery of pneumonectomy of a pleurodesis patient. It is really, you would understand.
Thanks.
Sure. So
Yeah, I think the surgeon will be cursing you, but we can get it done. That's the bottom line. If your patient is sick enough, not going to survive, this is the only option. We have to go through it. But definitely there'll be more risk of bleeding, and you need to plan it in such a way you have extra 1 or 2 hours for the surgeon to dissect the lung out. But it's doable. It's not like an absolute contraindication.
Just a quick comment before we close it. So in Mumbai, we did a bleomycin, induced pleurodesis. I mean, one of the patient which was referred to us had a pneumothorax, and the primary pulmonologist who had referred, he did a bleomycin pleurodesis, and then he was referred to us, and then we did a successful lung transplant. So I think, as Dr. Harish mentioned, avoid TAC, but there are other agents where bleomycin is something people are choosing it specifically when you think that the trajectory would be towards lung transplant.
So, however, talc is the most effective as per
Yes,
literature.
yes,
So,
yes.
I think
That's why avoid,
then it
because
should be
otherwise if it's most
mentioned in
effective, I
guidelines.
mean, it's going to
If
be
you are
10
considering
suggestions
for a
there.
transplant, avoid talc. Thank you. Thanks, sir.
so we conclude this session, and in the interest of okay, so in the interest of time, we stop the discussion. And after seeing the recipient selection criteria, the next very important aspect of a lung transplantation is donor assessment and management, which will be dealt by my colleague, Dr. Oves. Yeah.
Hello, good morning everyone. So moving on from the recipient side, we have to focus on the donor side as well because they are most important for survival. A good lung will lead to a good survival. So my overview will be why we need donor optimization, the pathophysiological changes happening in the donor. We have a small but important window for donor optimization, which can lead to increased organ utilization, the process, whom we can consider a donor, and the newer modalities for donor optimization. So this is the US data for the last 20 years. On the bottom, on the x-axis, you can see the donations, the living and the deceased donations, less than 20,000 in the last 20 years. On the top graph, the recipients on the waiting list, you can see the graph is rising. So there's a huge gap between the donors and the recipients. So in the US, in the last 10 years, approximately 30,000 donations have been happening from 2010 to 2019, just a marginal increase in donations. And you can see the yellow graph, that is the number of lungs harvested. That is just a small fraction, maybe 5 to 10% only. So this is the UK data of 1 year from 2022 to 2023. You can see of all the organs transplanted, the purple graph, this graph, this is of lungs. It's only 20%. So if you take 10 donors, only two organs of lungs you will harvest, compared to liver and kidneys, where 78 and 85% of the organs are harvested. Okay, sorry. Yeah. And the US data is also similar. 19.2% is the harvestation rate out of last 30 years of 1,31,000 organs. So what is the pathophysiology? So the patients have a traumatic brain injury or IC bleed, brainstem dysfunction happening. It increases the ICP, Cushing's response, and it leads to a sympathetic storm in the body. So it will cause have effect on almost every organs in the body. Lungs are majorly affected. They can be because of the neurogenic pulmonary edema, the reactive oxygen species generation, basic sympathetic drive, and increase in the inflammatory markers. Also, the heart, which is directly connected to the lungs, it can be affected by the RV dysfunction, the LV dysfunction, increased afterload, arrhythmogenic, all leading to lungs in pulmonary edema. Okay. So the overview of the pathophysiology which decreases the organ procurement in lungs and heart is sympathetic storm. Okay, the storm also has effects on other organs like autonomic nervous system. It increases sympathetic stuff, but sometimes it can also cause sympathetic denervation. Vagal and cardiomotor activity is suppressed. There is pituitary and autonomic system dysfunction with hypothyroidism, temperature dysregulation, most commonly hypothermia, hypercortisolism, sometimes hypercortisolism. There is consumptive coagulopathy, DIC, bone marrow suppression. There are breaks in lot of barriers leading to sepsis, the mucocutaneous barriers, the gut barrier, the inflammatory barriers. So all these lead to reduced organ harvestation. So why this storm is important? Because after brain death, this storm leads to lung injury, compounded by donor-related sepsis, aspiration pneumonia, mismanagement of organ donors leading to excessive fluid administration, also hypercoagulous state leading to thrombosis. All these lead to a massive inflammatory cascade activation, which causes a primary graft dysfunction if you take this organ. And primary graft dysfunction, which in further will lead to reduced mobility and mortality. Okay, so we have a timeline for organ donation. So once a patient is identified as a potential brain dead organ, and so once the coning starts, once the coning in means there is a brainstem dysfunction, Cushing's reflex is activated, there is an autonomic storm. So when the organ which is optimum, it starts declining. You can see that arrow. From optimum organ, there's a drop in the function quality. There is neurogenic, cardiogenic, pulmonary edema. There is activation of the inflammatory cascade. This cascade lasts for approximately 12 to 24 hours, maybe 72 hours or 96 hours. There's no fixed timeline. But if we identify this inflammatory cascade earlier, we optimize the organ, we can make it fit for retrieval. This is when the organ is inside the brain dead patient. New modalities have led to harvesting the organ and putting it in a lung machine, which I will discuss later, and making it further optimal for transplant. So once a patient comes to the hospital, probably RT or IC bleed patient, who is a possible donor? A donor is a patient who has a devastating brain injury or a mechanical lesion which is suitable for organ donation, like a huge IC bleed, huge infarct, not like a malignancy or something. Okay, benign malignant lesions still can be considered. And once we have identified this patient as a possible donor, we should think whether this is a potential donor. A potential donor is who fulfills the brain dead donation criteria. Okay, so the process starts that we have first identified the potential donors. We correlate the etiology of brain death and the signs of brainstem dysfunction and rule out any contraindication to organ donation. Once we have identified, we approach the family for consent organ donation, optimize the organ, and make it ready for retrieval. So India, we do almost all cases of donor after brain death. Okay, with the recent changes in the legislation, there should be increase in the trend of donor after circulatory death. Okay, so donor after brain death is a routine process which we do, which I have explained in the previous slide. With a consent, we optimize the donor. In the donor after circulatory death, most of these patients who are hospitalized and they are dying, you should identify that there is futility of care. So that is most important thing, because once we identify and we decide to take this organ, we don't have much time compared to donor after brain death. Okay, this is a classification for identifying patients of donor after circulatory death. Okay, there are 4 categories. The category 3, it's an elective withdrawal of life supporting measures when we consider that is futile for patient survival. Okay, this is the best category for organ donation, especially lungs. Okay, this is called controlled donations. So you can see organ procurement can be controlled on the left side and uncontrolled on the right side. Okay, so controlled donation, because we are deciding when to withdraw the life supporting measures, we are ready with the organ donation process when we are withdrawing the life supporting measures. Okay, Uncontrolled is because there is sudden cardiac arrest and we decide not to escalate therapy further. Okay, so the donor is not in the optimal shape. We need extra measures, the extracorporeal life support measures, like an EVLP, which I'll be discussing later for organ procurement. So internationally, I think uncontrolled DCDs only few centers are doing. For example, one of the most common centers is a Madrid center, which is doing uncontrolled DCDs. Okay. So donor management starts with management of all the organ systems. So first, to start with the renal, maintain an optimum urine output of 1 to 3 ml per kg. Rule out oliguria, anuria, or also diabetes insipidus. Optimize the electrolytes. Keep sodium, potassium, magnesium, phosphorus in the bench. Keep acid-base balance optimum. Precondition, you can start with dopamine. Okay. Correct the coagulation parameters because there will be consumptive coagulopathy, hypercoagulable state. Keep DVT prophylaxis on. If you can't give anticoagulant, at least mechanical DVT prophylaxis is a must. Okay. Maintain the perfusion, optimal CVP of 6 to 10. CVP might not be reliable. Target lactates, mean arterial pressure more than 65. Signs of organ perfusion like acidosis. Also, you can use continuous cardiac monitoring, pulse pressure tracings, and you can use a 2D echo on the bedside and IVC tracing. Okay, transfuse only if necessary because blood and other products will lead to sensitization of the donor organ. Okay, endocrine has to be taken care. Hypocortisolism, hypothyroidism are common. Also, diabetes insipidus has to be ruled out. Okay. So we give steroids, and thyroid is important. Thyroxine supplements, especially when the LVEF is lower, less than 45%, and refractory shock because it up regulates the cardiac output thyroxine. Respiratory system, we have to follow the lung protective ventilation, tidal volume of 6 to 8 ml per kg. Intermittently do recruited maneuvers 3 to 4 times a day of PEEP up to 30 centimeter for 30 seconds. After doing a suction or after an apnea test, that is the best time for doing a recruitment manner. Okay. Then also inotropes wise, you can use any inotrope, but as most of the patients go into diabetes insipidus, vasopressin is started first, then norepinephrine or adrenaline based on the LV LV cardiorespiratory system. Okay. With invasive cardiac output monitoring, it's always easier to base the inotropic requirement as per the SVR and the PVR. Okay. Cardiovascular system, basic goals like maintain sinus rhythm, heart rate 60 to 120, map good cardiac index of 2.5 liters and a good LV of at least 40 to 45%. Fluid should be always goal-directed fluid therapy as per basic critical care management. Monitor the cardiac output. You can add a dobutamine or dopamine if the cardiac output is not managed. Look for tachy or bradyarrhythmia. They are very prone for those. Okay, and it has to be managed immediately. Okay, so these are the basic goals in short, which you have to frequently monitor. So optimum map, CVP, ejection fraction. Inotropes should be kept at the bare minimum. Okay, especially noradrenaline or adrenaline less than 0.2 mics per kg per minute. Sugars should be maintained. Stress hyperglycemia is very common. Okay, and electrolyte dyselectrolyte also very common. So it is always better to have a checklist of organ donation, which shows that lines, labs, investigations, ventilation, cardiovascular fluid, and general case management. And every specified hours, you can tick on the checklist, like every 2 hours, 4 hours, 6 hours, you can do all those things. So the ideal donor criteria for a lungs, the traditional criteria like age less than 55, normal chest X-ray, PF ratio more than 300 with a PEEP of 5, smoking history less than 20 pack years. There should not be any significant chest trauma. No active pulmonary infection. No evidence of aspiration or sepsis. Bronchoscopy should be clean or minimal mucoid secretion. No active hepatitis infection. HIV, HBsAg positive should not be there. Active viral load should not be there. Okay. ABO should be compatible. No history or evidence of any malignant disease. So when the traditional criteria is not met, the organs can fall into the marginal criteria. This has been added because we need to increase the donor pool. Okay, so extended criteria is age more than 70 years. Minor, diffuse or moderate focal chest radiography changes are acceptable. PF ratio is less than 300 but preferably more than 200 on a PEEP of 5 after optimization. Tobacco smoking 20 to 40 pack years. Mild chest trauma if the pulmonary functions are good, there is no significant contusion then. Okay, aspiration or sepsis, if there, it's controllable. Aspiration, there is not much repulling on the bronchoscopy. Like if you do a suction, it should not reappear again in the segments. Okay. So that was a so this criteria is from the ISHLT 2020. So they prefer donor ratio PF ratio more than 400, P5 to 8, and rest of the things are similar. Okay, normal X-ray, normal bronchoscopy, absence of gram stain fungal cell. This is the standard criteria. So how do we optimize the lungs? We give PGE1 steroids, heparin during organ harvesting. Steroid we are giving during the time of donor optimization. Cold HMI time, keep it as minimum as possible. So donor lungs were traditionally stored in ice boxes. Now there have been more evolution. So now the optimum storage is considered 10 degrees. So Western world has moved more and more towards 10 degrees. We have also procured an organ box, and now also we are storing at 10 degrees in the last few months. Lung inflation while harvesting, and organ preservation solution, the Perfadex flush we use. Okay, we give it antegrade and retrograde, like through the pulmonary artery and through the left atrium, both flushing, to remove the clots and to preserve the organ. The next is after you harvest the organ, you can do something called EVLP. We have a workshop for that. I'm discussing later. Okay. So this is how a EVLP looks like. It is outside the body. It is in a dome covered with a transparent plastic or glass, monitoring the weight of the dome, and blood is taken from the LA, from the left atrium. It's run in a pump and a gas exchange filter with a solution. It's similar to Perfadex solution, and return to the PA. And the ventilator is connected to the lungs, which is outside the body, and we are monitoring the changes every 30 minutes hourly, and we are doing some adjustments on this circuit, so to make it ready for harvestation. Okay. So ex vivo, what is the role of ex vivo? This the machine which I showed in the organ harvestation. In the donor after brain death, when the lungs are of marginal quality, like the extended donor criteria, and in the donor after circulated death, whether it's controlled or uncontrolled donor after circulated death, it's preferable to use an ex vivo lung perfusion. Ex vivo is considered as an option for logistic purposes, but we have newer boxes like the Orgador system, the Paragonix system, which we can use a cold storage system for this. Okay, so EVLP gives us times to optimize the lung. Then we can decide when the lung is on the machine to take it or on it, if it optimized or not. So when a patient is brain dead, it doesn't meet the standard criteria of organ donation. That is the inclusion criteria for EVLP. There are few contraindications for EVLP, which we'll discuss in the workshop. In DCD, all donations are preferable, like uncontrolled or controlled, to include in the EVLP machine. So EVLP has been progressing slowly over the years. It has much more applications. Rather than just decongesting the lungs, it can cause, there are various biomarkers being developed. You can image the lungs on the EVLP machine. You can moderate the drug exchange. You can do immune modulation, gene therapy. These are all in the pipeline. To conclude, early detection of a potential brain dead donor, coordinate with the transplant team. Transplant coordinators will be them, alert them earlier, optimize the lung from the day one of potential organ donation. Okay, intensivists play a key role in organ donation, but we need still better clinical trials to optimize organs. Thank you. So I'll be moving on to the case now. I would like to invite Harish sir, Vijay sir, Unmil sir, and Pavan sir on the dais for the case report.
Why are you so concerned about vasoconstrictors in donor management? What is the relevance to the lung transplant? The role of vasopressors, excessive use of vasoconstricting agents in donor management. What is the relevance of it towards a successful lung transplant?
Okay. You want to? What is it? Okay. Uh, excessive, actually, excessive vasoconstriction, especially pulmonary, it will increase the pulmonary vascular resistance. Okay, and also the systemic vascular resistance, both. So uh, it will decrease the nourishment and it will cause pulmonary vasoconstriction. So there will be less. First of all, on the systemic side, there will be more end organ damage. If you are decreasing the perfusion, there will be more end organ damage. So a lot of trials have shown in the critical care, on the critical care background, that more than 0.2 mics per kg is classifies into severe sepsis with septic shock. The survival decreases, the mortality decreases because there is more inflammatory cascade happening in the body. Also, it leads to generation of more reactive species. The PVR goes high. Pulmonary vascular resistance, the pulmonary artery is one of the major things which has to be protected. There is loss in the endothelial integrity. There is break in the endothelial barrier of the pulmonary vessels. There is loss in the integrity of the alveolar capillary membrane when you give higher inotropic supports. All these lead to a more inflammatory cascade. Especially there are upregulation of inflammatory markers. So one of the markers which have been in the study now, which have been discussed, like they have been studying markers in gene expression profile, is interleukin 1 beta. It is upregulated when you give very high inotropic supports. Okay, that leads to more primary graft dysfunction post transplant. Primary graft dysfunction will lead to more chances of acute and chronic rejection. So overall survival is much lesser when you give higher inotropic supports. Yes, yes, sir.
How do they select their donors when they
Yes,
go
sir.
to site and they see a patient on 25 ml of NORAD,
Yes, sir.
300 ml of vasopressin, things like that?
Okay, so I'll be just showing a case report on how to optimize the organ donor. So basically, once you get an organ, so initial resuscitation should be judicious. I know RTA is there, so basic people will just flush with IV fluids, 1.5 liters, 3 liters. So RTA patients, you rather start up blood products in a balanced manner, like 2 PRBC, 1:1:1. PRBC, FFP, platelets, and cries also come. So blood products, because your patient will be hypothermic, will be hypovolumic. You with giving more fluids rather than blood product will call dilutional coagulopathy. So there's a term called dilutional coagulopathy. So there's a dangerous triad of hypothermia, acidosis, and coagulopathy because of injudicious use of IV fluids and non-goal directed management of these patients. Uh,
So whenever we used to get a call for a donor, so apart from the clinical criteria which we are sure that they will be matched and we are proceeding for the transplant. So in case if the recipient is a female and the donor is a male and the recipient is, for example, is an ILD patient, are there any criteria of matching on anatomical or a radiological basis so that we don't have an oversized graft or something like mismatching of the organ for the recipient? Apart from the clinical criteria, I'm asking.
yes, yes. So
Of size matching. Ideally, it's difficult to get a one-on-one, so the ratio of 0.8 to 1.2 up to 1.5 should be fine. We go by the height approximately. There is also an FEV1 predicted criteria for this as well. But invariably, some sort of a lung volume reduction will be required if it's a bigger size. All this can be done based on the recipient, how urgent this lung is. Can he wait for some more time? If the recipient is on an ECMO or other issues, and the lung donor come, we tend to be less stringent for these. So we take the lung, try to modify it, so we can do peripheral lung volume reduction, try to fit that lung, or we can knock on of middle lobes or some lobes if there is some more volume accommodation needs to be required. So that based on how sick the recipient is, how much can he wait, if he's not going to survive maybe few days or a week, then we kind of work with the lung and try to do the size matching or volume reduction to accommodate that lung.
One more question is like whether whenever we have a stable donor or if he or she is on a minimal oxygen support, is it mandatory that he or she should be on a higher oxygen support or clinically on a relatively unstable conditions to proceed with these type of transplantations? Or if the patient is rather in other way, if the patient is more in a stable condition, should we avoid for this transplantation, or is it mandatory to be in marginally unstable or oxygen support?
So you're talking on the recipient side.
Yeah.
Okay, so see, recipient side basically it all depends upon how sick is the patient. So if you're maintaining, also depends upon whether your patient is in type 1 or type 2. That will also determine the need for the oxygen requirement. And so I think the best possible would be to have at least a saturation above 90 for it's an end stage lung disease. So we cannot aim for 100% saturation. Okay, so at least you have a saturation above 90, but it all depends upon whether it's hypoxic failure or it's a hypercapnic failure, or if the patient is in the hospital setting and awaiting a transplant. So it all depends upon that. If the patient is at home on 3 liters, 4 liters, 5 liters, he's already into this chronic lung disease state. He's been on a chronic LTOT therapy. So that is a totally different scenario. But in a recipient, it's not mandatory that it has to be always a high oxygen requirement is required to, for the to go for the transplant. No. And also answering your first question about the size mismatch, some of the centers they do volumetric CT scans also wherever the facilities are available on the donor and the recipient side, and that also gives you a fair idea about how do we match those volumes.
I'd like to bring in Dr. Govini's insight on it.
Yeah, I think there are calculations which we have to go through before deciding on this. That's a total lung capacity kind of things. And then you have to visual inspection, and second, comparing the CT scans and X-ray and volumetric study. So you have to combine together and then take a decision on this. Still, you feel that there is a challenge in implanting the lungs. You can go for a peripheral reduction, or you can go for a middle lobe or the lower lobes.
Because recently we have encountered one case in which we have got the height of around 170, and on like when we went for the transplantation, the height was 155. So there is a disparity of 10 to 12 centimeters.
So that is
That
acceptable.
completely changed the scenario. So what I was asking is basically, is there anything which we can do radiologically or apart from the height and usual clinical parameters from which we can have a better match of recipient with the donor?
See, if your mismatch is more than 20%, then you got to look for the surgical reduction.
And this reduction has to be done the pre-implantation or post-implantation?
See, either way you can do it. Okay. So normally the lobectomy, it is easier to do in a back bench.
Prior to implantation?
Yeah. Do the lobectomy and then implant it, because it is easier to do. Once if you implant, it is very difficult for us to do the lobectomy. If you're going for only peripheral resection, then implant it and see is there any 10% you can reduce with that.
Just one.
No, it's all right. The great questions. I'm sure it's relevant to the donors that you are trying to evaluate. But having seen more than 1,400 lung transplants thus far, doing volume reduction from the donor recipient, that needs to be avoided as much as possible, because it will create worse situations than you could have otherwise. So better match it, or just let go of the donor, find a better match. Oh, that's a great question. You should see in my article, bigger the better. But if there is a huge size mismatch in restrictive lung disease, you should think about doing a single lung. The mediastinum shifts, you can accommodate a 40% over TLC. And they do fine for 10 years, single lung. And use the other lung for another person. And the pressure use in the peri-transplant area, the one more factor is bronchial submucosal constriction Airway ischemia, that's real. And your anastomosis healing is compromised, especially alpha agonists, more so than beta or vaso.
Yeah, absolutely. Thank you for bringing that up. That's specifically what I wanted the audience to know, that when you select patients, preoperative vasoconstrictor or vasopressor scores are extremely important because they could be prognostic in the outcomes of the operation. One of the other questions that Harish I would like to bring up, Dr. Govini is also he has a lot of experience with lung transplantation, is about the method of anastomosis. I don't think we have a surgical discussion right now, so I think we had a conversation yesterday, continuous.
So let's start with surgeons. So Dr. Govini, how would you like to do your anastomosis? Bronchial.
Bronchial we'll allow to do with the continuous suturing technique.
Continuous.
Yes.
Why?
No,
Why
it's
not
it's a
interrupted membranous and interrupted cartilaginous and continuous membranous?
No, either way we can do it, but surgeons are more comfortable doing in a continuous manner.
Okay. Is there any benefit of doing membranous continuous and the cartilaginous portion interrupted?
Yeah, because the posterior normally will go continuous, the anterior you can go for the intermittent as well. That is the other way of, because sometimes, yeah, it's not clear.
I don't know if there is clear data surgically. So one should understand how this started. The patient, James Hardy lost that patient in 18 days because the bronchial stump just fell through. The patient developed a huge emphysema after the transplant. So bronchial anastomotic patency is the key. So people have come up with several, as you know, Norman Shumway, Cooper, Alec Patterson, whom you work with. They all have a understanding and the process of how it developed. What to minimize your airway complications, I don't know if there is any benefit of doing one way or the other, but the key is take as minimum bites as possible and do not keep the anastomosis too tense, especially the membranous. Take as minimum bites as possible. So, in fact, when you're in the OR, I'm counting how many membranous bites are you taking. So 14 on the right side, 14 to 16 on the left side, 10 to 12. If you're doing more, then we need to rethink and we need to have a back table discussion.
Yeah, normally our calculation will be the posterior 4, anterior 4, laterally 2, 2.
Okay, 4. That's.
No, again, it is not for every cases. Yeah, depending upon the bronchial size of it.
The right, it may be a little bigger, so you may need to put a little extras.
Few more, yes.
Yeah. So the key is try to keep it as minimal bites. I think 6 is too small on the membranous. I can tell you upfront. 6 is too small. You may have better.
American bronchus.
See, if the gentleman's question before, female lung versus male lung, that's such a remark that's not well taken in rest of the world. Female lungs are as good as male lungs, are as big as male lungs, so they do just fine as male lungs.
I had another point, Harish. I think why I would give some credence to that question is, especially with women, if you have a lesser anterior posterior diameter and you use a male donor in a female recipient, the male lung has a tendency to kind of come anteriorly because it rolls over and then it causes a lot of compression on the heart post-operatively. One of the main reasons that we have noticed that we've had to routinely leave chest open in gender mismatched transplants is largely because whenever we've used male donors, almost height matched male donors, weight matched male donors in females, we've seen the lung come all over and compress, especially on the left side. So we've had to leave chest open. We've had to use all those methods to allow some of the edema to resolve over the next 24, 48 hours. So maybe that question has some substance.
Possible. Yeah.
To perform, where they do lateral thoracotomies and they put in the lungs. Is there a better way to assess the size match? Because we are doing a lateral thoracotomy and putting a lung vis-a-vis a clamshell incision where we have enough room to implant the lung and then wait and then see what we can do for a peripheral wedge resection or whatever.
Anterolateral thoracotomy is primarily for post-op recovery phase. And if you have challenges with size matching and all, I think clamshell is the way to go. If you have a straightforward case or a patient with a lot of other comorbidities, obese, weak, or myopathic, ECMO, anterolateral thoracotomy probably would be benefiting in the immediate post-op recovery. If you are trying to do wedge and all, you are going to convert it into a clamshell anyway.
So if the recipient is a status post CABG, where doing a clamshell, would that be a problem? So in that case scenarios, no, in that case you will do a sternal sparing. So how do you size match in that scenario?
Do a single lung.
Yeah, but still
No,
size
no.
matching is still important because we
Just
do.
do a right single.
No, but cabbage, is the graft exteriorized or not, and how comfortable the surgeon is trying to preserve the graft, and how dependent the patient is on the graft. Not all grafts need to be preserved. Sometimes the graft is gone at 2 months post cabbage, and the guy has a decent rate of coronaries to survive. So, so for I think clamshell can safely be done post cabbage. There's no limitation as long as one knows how to preserve the graft.
One of the challenges there is largely if you use the mammary, I think a clamshell, mobilizing the clamshell, the upper flap is unfortunately slightly taxing. It would lie probably almost in the course of the, I would say, the mediastinum on the left side as you open it up. But more importantly, with bringing up live grafts, I think assessing the patency of graft preoperatively and lying there, understanding their lie is very important. On the right side, especially the right coronary artery, the vein graft on the right side could be lesser of a challenge compared to the left because a circumflex graft would lie almost in very close proximity to the left-sided pulmonary vein cuff and also to the left atrial appendage. Mobilizing them during surgery could be of serious consequences. The mammary, if used, would obviously lie probably in very close proximity to the phrenic nerve on the left side, and thereby it could be a serious matter. So if you look at if you're looking at a lung transplant in a post cabbage setting, I think doing a single lung on the right would probably be the best way forward. I mean, unless you want to risk the left.
Yeah.
You have anything to say? Any other questions? I'm sorry, the entire idea here is to bring as many questions as basic as they may sound, so that all of you can get some, thoughts to probably come up with a follow-up question. So please, the encouragement is to feel everyone, to think about something and come up with any questions.
Yeah, regarding the bronchial anastomosis that you mentioned, rather than the technique, we also do lung transplantation Medanta, and we have the experience in tracheal resection anastomosis as well. So more than the technique, the part of the recipient bronchus, how much you are leaving in the recipient. So we leave one ring on the right main bronchus on the recipient side and maximum 3 rings on the left side. So probably that also will take
How many on the left side?
3 rings, maximum 3 rings. So as close as to the carina is that's what we follow.
I don't know if the recipient bronchus has any effect, but we want the donor bronchus to be as short as possible.
So donor as well as recipient. In donor, we cut the bronchus as close as to on the right side, the right upper lobe origin, close to the right upper lobe origin. On the left side also at the part of secondary carina.
Yeah. So I think
because several institutes have their own way of doing the anastomosis. The Vienna group does continuous anastomosis, and they reported less than 1% of anastomotic complications. The Toronto does in another way. So, but every institute has, depending on their technique, how they do in their routine practice, it changes. But the golden principle is probably is respecting the tissues and doing the anastomosis, they said.
Yeah, minimal dissection, keep the
Absolutely.
dissection as minimal
And
as
keeping the
possible.
subcanal lymph node pocket in situ,
Yeah.
which is another important
But I don't know if leaving the recipient bronchus any shorter or longer has any effect on the survival of the anastomosis. I'm not aware, but I may learn.
Yeah, but the thing is, you should not denude too much around the
Absolutely.
bronchial area.
That
That
is
is a very important
yes.
focus. Normally, what we do is we just leave the right side one ring on the recipient side, and on the left side we'll leave at least two rings. And it is more important on the donor side. See, there is a no man's zone, so that you have to give the importance to that. Okay, and it should be not in a tangential or longitudinal. It should be a like a your what you call longitudinal cut should be there actually. It should be like a cross kind of things on what you call angled cut actually. You have to do it in the donor. Oblique cut they say.
Sure.
No, don't use a cautery. Use always a knife. Peribronchial tissue need to be preserved in those cases.
On the left. Bala, I also wanted to bring this up. What is the and Harish, what is the relevance to this question, especially given the fact that what if you ever require a future airway intervention in the form of a stent? So I think that's an important consideration. If you try to reduce the number of rings on the recipient side, you probably almost end up with an anastomosis right at the hilum, and that has a huge relevance in the long-term, implication.
True, and you may one ring is enough to center a stent. You have a 2-3 centimeter stent. If on the right, one ring. On the left, one ring from the donor end may be good to center a stent. But you're doing a surgery thinking that you will not have an airway complication. So you don't want to modify your surgery to accommodate for an airway complication in future. So stents can be improvised. So I think surgery is the gold standard. I want to view lung transplant surgery in a way that I have gone through many surgeons in my career, and I have the utmost respect for a person who wants to do lung transplant surgery, because I have seen surgeons with cardiac background, thoracic background, from St. Louis background, from Toronto background, from Australia background, whatever backgrounds. It is very taxing, very painstaking surgery, and people need to keep their cool, do their best every time. And that has to go picture perfect for the rest of the life of the graft. So variations in surgery have to be limited. Whatever the person is comfortable, you keep it that way. Improvisations on the post-op complications can be done.
I think what others said about not devascularizing it is probably the most important thing, rather than trying to sort of, spruce it up completely. I mean, we've had a very large number of tracheal, but I think that's probably one of the most important factors. That, and as far as the your comment about stenting it later or need for stenting later, I think it's possible now to get a customized stent in almost every case and do it accordingly rather than sort of having to bother.
Yeah, in fact, some of the centers, they had a bronchial artery anastomosis also, but not much difference actually if you do with the bronchial artery anastomosis or without bronchial artery anastomosis. So only that it will be a time consuming because ischemic time is more important here.
Great point. Bronchial submucosal plexus supplies the anastomosis. So post-op care, pressors, PEEP, infection, those are the factors that are driving the complications after the surgery. So doing an arterial anastomosis, the surgery can only be done one way. And there is three tubes, you're going to put it together. So, yeah.
Especially Harish, in the Indian context, we barely get any ideal donors who are ideally managed through the process of organ donation, optimization, perfect surgery, so on and so forth. Even if they escape all of that, they end up with some kind of airway colonization very early on post-operatively. Most centers do not have the ability to have isolated facilities for purely transplant patients or bronchoscopes or airway integrating devices specifically to transplant patients because it's a huge investment, except a few centers like ours. So given that fact, eventually donor airway colonization is an eventuality that all of us live with. And the degree of remodeling that happens once we have a quorum sensing of a chronically non-treatable bug in the airway has a huge impact on how the airway responds after transplantation. So I think for the surgeon to either take credit for the avoidance of an airway complication or to blame himself and beat himself to death, thinking
Oh,
that
that I have a clear answer. Airway falls because it's a bad surgery.
absolutely.
This is from the words of Dr. Keshavji. I'm going to quote him. He said, airway falls apart because it was a bad surgery.
Yeah, I agree.
So I have no other.
Dehiscence for sure. Dehiscence for sure. In the support of the surgeons, dehiscence for sure.
Yeah.
I don't see any reason why dehiscence can be kind of waved away by your wish. Dehiscence I think is unforgivable. I do understand, but many other complications, especially in the Indian setting, are inherent to where we practice.
So that's a learning curve. So I'm sure donor management also weighs a lot more importance. So early involvement of the pulmonologist in the donor management is key for the success of the program too. So you take over the care of the donor and then run the show.
Right. So quite prolonged discussion. So we'll cut down on the case which Oves was supposed to discuss because most of the things are covered in the discussion.
Yeah, yeah, you can present it.
Fine. Yeah. Okay.
We can skip lunch.
Okay.
Matters when you go for retrieval. The volume of Perfidex and how do you decide like and what are the long-term, short-term outcomes of it?
Yeah, it does matter. You got to have a good flush. Not every flush is going to be the same. Not every lung is going to be the same, especially the retrograde. You need to have your flush to be clean when you're coming up. So it's not a specific volume, what you're getting during your flush. And until it clears, you have to be patient. And the pressure at which it runs has to be keyed in too. You cannot high too high. You cannot do it connected to a pump. And those are the factors one needs to pay attention. Some people carry a scale and measure where the bag is hanging. I don't think the volume matters, but if as long as your return, either from the vein and the artery, is clean, you're fine.
I'll just present the case briefly. So this is a live actual case happened like last week. So 50-year-old gentleman, hypertensive, O blood group, with a height of 162, idle body weight of 62, and a BMI 23.6. He had a two-wheeler. He was riding a two-wheeler, had a collision with a four-wheeler head-on. Severe traumatic brain injury, GCS of 5. So the detailed examination in the ER, only closed head trauma, no other bleeding in the body, no chest trauma, just fluid resuscitated 1.5 liters and taken for a CT brain. So CT brain, you can see a large bleed extending into the ventricles. Also, he had a pontine bleed. So pontine bleed has a poor prognosis. So he was considered as a potential donor. After 24 hours, his GCS dropped. He became brain dead, absence of brainstem reflexes. He was not on any sedatives. Just for confirmation, an EEG was done. Is one of the ancillary tests for brainstem testing. It was flat. So, on consideration of the factors, the etiology was considered brain death. There was no other contraindication. It was a bleed because of trauma. Brainstem testing was done on 2 occasions, 6 hours apart, and then consent was taken once the test was positive. So for the management, you go by the initial management. Okay, donor optimization has started from the day one when the patient has come to the ER. This is the assessment. So assessment was blood group was O. We need ABO compatibility. Height 162, weight 62 kg, idle body weight. That was size match. So size match 5 centimeters here and plus minus, or ratio of the donor and the receiver 0.9 to 1.1 as just discussed. Or you can do a volumetric scans. Okay, which might not be practical in everything. Okay. Routine screen was sent, complete blood profile, CBC, LFT, RFT, coagulation profile, peripheral smear, sepsis panel, blood, urine, ET culture, procal, ultrasound abdomen, any other free fluid, any other bleed, any other issues. Do a chest ECG, 2D echo for contractility, volume status, regurgitation, chest X-ray and CT scan. Okay, this was the initial lab. HB was 8.4 because of many factors. Counts were 4,500. There were platelets were slightly low, 86,000. Manual count was done, 90,000 cross check. There was no schistocytes, no peripheral feature suggested DIC. Coagulation, APTT was a little high, 54. Creat was okay. Sodium was 147. Potassium was 3.3. For the lung assessment, clinical examination, no external injury, no external abrasion or something. Chest rise equal, auscultation or bilateral breath sounds. X-ray was fine. So CT, I just play the CT. So upper lobes are clean on the CT. And you can see the fissure dividing the superior basal segment has come the lower side. You can see some basal atelectasis or aspiration, and the right lower lobe. You can, and the left lower lobe posterior basal segment, you can see some collapse consolidation. Okay, this was the initial ABG. So FI to 50% P per 5. Tidal volume was as 6 ml per kg of the idle body weight, so 360. So PF ratio was 200. Okay, 107 divided by 50. Bronch we did at the entrance of the carina from the ET to distal and the ET team. You can see this blood clot is extending into the right main bronchus on the left side. Okay, so bronch is sent for routine investigation. We also do a biofire multiplex PCR, gene expert, COVID also we are doing it. Okay, so AFB, bacterial culture, fungal stain, tuberculosis, COVID RT-PCR, multiplex PCR. Okay, in India. So bronchoscopy I'll describe. So first thing is you have to look where the position of the ET tube is. It's above the carina. Okay, now we're going into left main bronchus. So this is after cleaning. You can see some clots in the posterior tracheal wall. Left upper lobe is clean. Lingula, this is. You're going to the left lower lobe, it's clean. Some hemorrhagic patch is there. Okay, after there was some blood clot, we have cleaned. This is post cleaning. Okay, So right side, the mucosa is pink and healthy. Okay, not much secretions. Okay, erythema is there in the lower lobe. Okay, it is at the site of superior basal segment. You could have seen in the CT scan there was a collapse corner. That side there is some erythema. We have taken sample from there, right low. So we have taken sample from the right lower lobe superior basal segment and the left lower lobe posterior basal segment coinciding with the CT scan where we found the secretions. So ventilator management, lung productive ventilation. After bronch, we did one recruitment with CPAP of 30 centimeters for 15 seconds. We can use any maneuver. Okay, so this was the settings kept. Okay, and this is the follow-up ABG, PO2 175 on FI 250. Okay, so PF ratio is improved more than 300 now. Okay, fluids, she was positive by patient was positive by 300 on day 3. CV, so fluid was given goal directed. CVP was targeted at 6 to 10. NORAD as 2 ml per of 8 by 50, that was coming to 0.08 mics per kg per minute, less than 0.2 mics. Nutrition was continued. So for hemodynamic management, CVP, arterial tracing, and 2D echo. So you can see on this simple monitor, there is no arrhythmia, sinus rhythm. You can see the CVP is in single digit of 7, and you can see the arterial pressure tracing. Okay, there is no pulse pressure variation. Okay, so all graphs are of equal size. There is no graph which is very small and very large. Okay, that is pulse pressure variation. So up to 12% pulse pressure variation is acceptable. Okay, more than 12 means patient is intravascular depleted. Okay? But no single parameter can define the adequate volume status. Okay, you have to take multimodality approach. We did the echo. Echo, this is the long axis view, LV. You can see LA is opening into the LV on the left, it was okay. This is a short axis view on the right side. Okay. So LV, RV, LVA was okay. So contractility is fine. Now we also have to see for the functional regurgitation. Okay. So there was no significant regurgitation. PSP was only 30. Okay. So heart was good. So hormonal therapy, for the endocrine, steroid we gave 15 milligram per kg, 1 gram we given. Thyroxine was given 300 microgram relative. Some recommendations are there to use a continuous infusion of thyroxine. Okay. So electrolytes, urine was monitored continuously, one of the most important parameters. Okay, so 1 to 2.5 ml per kg urine output should be there. Okay, up to 0.5 ml is obligatory urine output, but 1 to 2.5 optimal. So it was around 60 to 100 ml per hour. But then for 2-3 hours, urine output started increasing more than 240 ml per hour. One output was 300 ml, and then it started continuously. Fluids were given, and we did a repeat labs. You can see the sodium; it came out to 169. Okay, so patient had gone into DI. We gave a dose of desmopressin, 0.1 mics nasal spray. Okay, and then follow up after 6 hours. We repeated sodium; it was 156. Okay, now the counts were 12,000. Plated was still 60,000, but there was no active bleeding, so we did not transfuse because there was no active bleeding. Sepsis panel urine routine was normal. Cultures were negative. USG abdominal, no other foci. Procal was 1.2. BAL multiplex PCR was pseudomonas, which was NDM positive. Culture takes time, so multiplex PCR is little sensitive, but we have to be careful. It can just be a colonizer, okay, and can lead to more false positives. So ceftazidime, avibactam, and astenolone was started in view of NDM positivity. Other basic management like critical care management like normothermia, you follow the fast hug bridge criteria, head and elevation, stress ulcer, DVT prophylaxis, and you stop all the unnecessary medication which is not needed. Okay, it has to be stopped. Okay, so all these things in summarize that PF ratio was good, CT scans some minimal changes, but bronch also was clean. So we took a decision that there are no obvious contraindication, there is no resistant infection, there is no other significant contraindication that this lung can be considered for a evaluation. We open the chest and we take a final decision for transplant. Thank you.
There is one or two things which will make you say this lung I'm not going to go for.
Okay. Yes, ideally, yes, definitely. I will do. So we use a fiber optic single use bronchoscope. Yes. That is easier. So yeah, so some is single use fiber optic bronchoscope is the best possible thing because we are just doing a simple bronchoscopy for washings. We are not doing any intervention. Okay. So we are not worried that the bronchoscope is already colonized with bugs from previous patients. So that is the thing. Okay, and so bronchoscopy wise, if there is a lot of secretions, purulent secretions, even after cleaning, there is repooling. That is one sign that we will not take this lung. Okay. So final decision will be taken after the opening the chest. Also, after bronchoscopy, after recruitment, PF ratio is gradually declining. Okay, we might need a relook bronchoscopy after maybe 12 hours or 24 hours. You see if there are secretions happening, or sometimes it happens that initial CT is fine, patient has developed mild sepsis, then gradually progresses into severe ARDS, or heart has depressed, or the patient has developed AKI. So there is pulmonary edema because of cardiac cause, fluid overload. All these factors will lead to low PF ratio and might decline the lung on those back factors also. Lungs are boggy. So only boggy edematous lungs, they can be optimized after harvesting on ex vivo lung perfusion, EVLP. Okay.
So for optimization, you are there on ground or you do it on?
So yeah, so if we have an in-house donor, we can do the optimization from day one. That is the best time. We are in the window for optimization. But if the lung is from some other place, if we cannot reach the, if most of our lungs are from the state, but many a times we get called from outstations. So like yesterday only we got one lung from outside from Mysore we got. So we have just reached the organ during the time of harvesting in the OT. So we could not ideally optimize the lungs.
So suppose we get one alert from
Yes.
somewhere that this is
So the
patient
most practical
donor.
aspect is ask them for the reports, like X-ray. Most of the centers won't do a CT scan. You just request for a CT scan first. If there is a local pulmonologist, request them to do a bronch and take washings from the areas on which CT scan is showing some source of infection or collapse. Okay, and better if you can request them to run a biofire or multiplex PCR, you'll get a result faster in 6 hours or so. Okay, cultures will take 48 hours. So you can ask them to recruit the lungs after bronchoscopy every 3 hours. Keep the equal balance. Can keep in contact on phone. Okay, and ask them for serial reports. So you can optimize from your area also, but yeah, you have to liaise with the real challenge will be you have to liaise with the hepatologist there, the transplant hepatologist and the nephrologist. So they will have little different goals. So they would prefer more fluids, over judicious fluids because they want to perfuse the kidney and the liver. So that is the challenge we face. The most of the times the lungs are very boggy. They are positive by 5-6 liters, 8 liters. Also we have seen in 4-5 days.
I'm going to add for that situation. What we have seen when you don't have ex vivo capability is after you have visualized the lungs, you can give additional doses of diuretic intra-op.
Yes.
One. And you can always infuse some albumin before you start your Perfidex too. And more importantly, how is the LV and are you hypertensive, which is driving the fluid back into the lung? And those are the three common situations you can do there when the chest is open to act working on decreasing the lung fluid at that time. I think you're young and you want a CAT scan on every donor. That's good for you. In real life, getting CAT scans on every donor is a luxury.
Yeah.
And you have to make your decision. When I started my career, CAT scans were not done, and we did 100 transplants without a CAT scan on donor. So, but this is the generation where you see a CAT scan, you see a spot, and you would think there is infection or something. And things are changing, but we only did CAT scans to look for cancers in a high-risk donor. That's the only reason why we did a CAT scan. And we didn't do CAT scans to identify infection, atelectasis, aspiration, edema, nothing. And now it's a routine practice.
For RTA patients, then you should do because there may be lung injuries.
Okay. If there is a contusion, then one would like to know, hey, is the contusion getting better? So you want a repeat CAT scan. Instead, go take a look and see how it is and whether you can manage that risk on your recipient would be a better alternative to increase transplants. If we have a contusion on a primary CAT scan, we are asking for a repeat CT. And now most of the organ procurement organizations just do a repeat CT just to prove that it is getting better.
Yeah, if there is any fear phrases like borderline kind of things, and you don't have much of the time, you can do the pulmonary vein sampling and then see, because that will gives a clear idea whether PF ratio is better or not. So, what is your word on that?
Oh, I love pulmonary vein sampling. Without bias, I will not accept. So I don't know how it works, but at least in my program, if I'm not comfortable, transplant doesn't happen. Because I'm the one taking care of the patient. I'm the one responsible for the patient. So it doesn't happen, no matter what you show. So without pulmonary vein gases,
So this happens when you are on site to comments. Yes. Open. That means already you have potentially accepted it. Yeah. Yeah, kind of just making sure.
okay, actually, you're probably looking for when you don't have adequate information, the lung looks boggy, there's a contusion, there is a lot of aspiration on bronchoscopy, and then you do the pulmonary vein sampling. And if it is not adequate, as in it's not more than 300, then you may be deterred to take the lung. What we have seen, normal pulmonary vein gases, everything looks good, you can develop severe PGD. And suboptimal pulmonary vein gases, but your visual exam is good, it can do well too. Off late, if the point of doing pulmonary vein gases is there a brewing ongoing pathology that you have not identified based on all the things you have already done and you can't see, or there's a clot, there is something that has went in before you can see, because most clots go to the lower lobe and the lower lobe vein gas may be the one that's abnormal. What we have done, if the vein gas is bad but everything is better, you do extra retrograde flush on that lobe. Try to see if we are getting effluent and how it's coming. If your returns are under high pressure, you will not take that lung.
My question to Dr. Sandeep, sir, here. The indications of when you can take it, the donor criteria are okay, but in practical aspect, so what are your absolute contraindications that you see the patient profile and you say, no, I'm not going to take this organ?
Repooling.
I think in Indian context, I would say we are worried most is infection. All other things is relative to how sick your recipient is. That is the reality actually. But if there is something that we are very worried about is how bad is the infection. That is, I think that makes sense.
Sir, I have one doubt to Dr. Harish sir. Sir, have you ever, any of your surgeons in your case, supposing if there's the pathology is involved only in one of the lobes, do you do a lobectomy, sir? Does this happen? You're doing a transplant of 3 lobes, either so you're doing lobectomy on right or left side. Because rest of the PV samples are good enough, they are more than 400. only one lobe is less than 200 or 150, and you know sure this is the one which is, so the rest of the three lobes are absolutely fine. So
There are cases where we have just gone ahead with the transplant, disregarding that number, and patients did fine. And there are cases, but we never resorted to doing a lobectomy based on the pulmonary vein gas. But we try to understand what is the pathology that is driving it more than anything else. The two common things that can happen, especially in the left lower, when you are lifting the lung, their cardiac output is dropping, and the patient doesn't have a blood pressure. So your gas is going to be low. So that's one. And number two is if you have a lot of atelectasis and you're doing Valsalva to recruit the lung, and again you're hemodynamically unstable and your gases may be suboptimal. As in there is no real pathology, but the vein gases are suboptimal.
That's generally the finding when we have heart teams that are, kind of picking the heart repeatedly, and then you do a sample, and then you get a bad value. So
yeah. So, I think that should be standardized by now, you know. You should pick all the common bug that you have in your, what do you call that? Every institution has an antibiogram, and you should go by that. Based on the sensitivities, you should institute the appropriate antibiotics.
For the donor.
Yes. Can we extend this to
I think, in the interest of time, we have to move on. Otherwise, this will keep going on and on. I think during the workshops, we can approach Dr. Harish for individual questions. And
but they have more experience now in infections, and
sure, you can approach
them.
any of us. But let's go on with the next topic, please.
I would like to invite Dr. Anup Mohandas, who is a senior consultant cardiac anesthesia in our team, for the next talk on ECMO as a bridge to lung transplant.
Good morning, everybody. So, ECMO in lung transplant. So, in first case of ECMO used as a bridge to lung transplant was done in 1975. In 1991, Hanwar Group published their first report of long-term survival after using ECMO as a bridge to redo lung transplant. Same team in 1992 group reported the first long-term survivor after using ECMO as a bridge to primary lung transplant. So application of ECMO in a lung transplant, it is for bridging with ECMO to lung transplant, that is pre-op, and then intra-op ECMO during lung transplant, and the post-op ECMO to treat the primary graft dysfunction. So bridge to transplant. So what are the points to consider? The patient selection, duration, rehabilitation, allosensitization, infection, and the exit strategy. So patient selection, the patients mostly we prefer already listed one, suffer acute decompensation, and then their moderate functional status is good. Second type of patients which are post-COVID or post-ARDS non-recovering, and there's clear potential for recovery, and there are only single organ, that's other organs are fine. Duration, we can see one patient which we inserted ECMO for ARDS in May 22. So date of surgery is 3 months down the lane, that is August 22. ECMO removal was done after 4 days post-op, that is on 16th August, and went out of ICU on September and discharged from hospital from October. So nearly 5 months the patient was with us. So this is a challenge. Patients on ECMO who are bridged to lung transplant stay with us for a long time. So long time issues like infection, rehabilitation, so financial, all these things comes up. So these are the challenges. Challenge with prolonged duration, the patient's relative and the family should be counseled that he'll be here for a long time. Financially, he should be back up. The family should be ready to be shifted from, the patients are from other cities, that they come here for ECMO support. They are out of the city for more than 6 months. So the family should be ready for the long-term thing. And then next is the patient with us will be in 5 months, 6 months. So rehab, the nutritional status. The patient can't be completely sedate, paralyzed, and then you do a transplant and find that he'll be fine. And he doesn't get a good nutrition protein requirements will be very high, and then you don't provide nutrition and then do a transplant, then it will be a failure. So the second challenge will be the nutritional status. How to maintain the nutrition during this long course of stay in the hospital. Then next important thing is rehabilitation. How quick you are getting the patient on an ECMO out of the bed, mobilize him. So don't target the saturation. Patient should be awake, talking to, trying to at least communicating to us, doing as much as physio to us. Lactate, urine, other organs are fine. The saturation of 80-85 is also good. So the rehabilitation is a key. Without a good physio rehabilitation, doing a transplant is of no use. And really realistic chances of organ availability for the patient with size match and everything. And then the final cost. So the most important thing is rehabilitation. The patient should be awake, sitting, mobilized, walking as much as possible. Patient who are bridged to a transplant should be as mobile as possible before a transplant. So physio, more we invest in rehab, better the outcomes we'll get. So what are the advantages of awake bridging? Avoid side effects of mechanical ventilation, sedation, allow mobilization, improves organ function and general status, provide optimal condition for transplant. So next, allow sensitization. Like we have already discussed this. Patient on an ECMO will be requiring blood transfusions. Avoid as much as possible, but still some of them will have low platelet, like COVID or ARDS, having multiple infection, long-term waiting for a transplant. Then we give a blood transfusion, and then we see they get. First they were not sensitized, and then they go and they get sensitized. Then we have to go do a desensitization for them. So next, what is our protocol for allow sensitization? Recheck PRA level if the patient received multiple blood transfusion on ECMO. Plasmapheresis and IVIG if PRA is high. Recheck PRA level after doing the plex. And then possible prospective cross-match for the patient. And post-op before discharge, early biopsy to rule out any rejection. So next problem is the infection. Preoperatively, the recipient should be as infection-free as possible. But patient on an ECMO in hospital, the chances of having some other infection are high. So what we do to avoid the infection? Strict isolation, 1:1 nursing, regular biomarkers assay, serial cultures, and antibiotic stewardship. So what is the exit strategy? So we put a patient on an ECMO, recovery is possible, then recovery and decannulation. We put a bridge, then we have to decide whether a patient other organs are fine, where he is doing fine. Then we can think he is a candidate for a single organ, then lung transplant. Then if he is having other issues like stroke, multiple organ kidney disease, liver failure, uncontrolled sepsis, and we are not able to control this one, then palliative or withdrawal of the ECMO. So factors affecting post-transplant survival in a patient on an ECMO. So what are the favorable factors? Age should be less than 50, normal or marginally increased pulmonary artery pressure. ECMO as less than duration, preferably less than 14 days. Low SOFA score, non-invasive ventilation, ability to the patient's ability to participate in physical therapy. So unfavorable conditions like greater than age, higher bilirubin, severe pH, prolonged ECMO more than 14 days, prolonged ventilation, SOFA score of greater than 9, major bleeding, major infection, and other organ complication, retransplant with a retransplant interval less than 1 year.
I would add one more.
Yeah.
If we go back to the previous slide. Favorable factors, high BMI.
Okay, sir. So efficacy of ECMO as a bridge to transplant. So there are multiple articles. This is from Tokyo. ECMO is efficacious as a bridge to lung transplant, has shown good post lung transplant outcomes. So next step is use of ECMO in intra-op. So intra-op ECMO for lung transplant, it is depending on the centers. Some centers do it for all cases on a central VA ECMO, and some prefer CPA bypass. Some try to do only few cases which are high risk on an ECMO. So what is the indication for ECMO intra-op? So that is RV dysfunction, severe PA pressure, prolonged ischemia time expected, borderline organ, and I said institutional choice. So intra-op mechanical separate support, what can be done? One is central VA or peripheral VV type thing or a CP bypass. So each has their own advantages. CP bypass, what are the disadvantages in CP bypass is that ACT required is higher, chances of higher bleeding, higher chances of CIRS response. So in a central VA, what happens? Advantages we can do at a lesser ACT of 180 to 200. We can do peripheral or a central cannulation. Priming volume is small, CIRS response is lesser, and post-op PGD has been shown lesser with a central VA. So advantages of intra-op ECMO, avoid hemodynamic instability. We use centrifugal pump, lesser inflammatory response. Post-op prolongation, if there is requirement for post-op PGD or borderline lungs, we can use it post-op. So what we do is normally use a cell saver with the ECMO. So hybrid ECMO configuration. So that's what we use. So coming then, weaning of the ECMO in the immediate post-op, important points. First, we check the anastomotic site, any repooling of the secretions of the reperfusion injury, the really PGD fluid, any lobar rotation and during the anastomosis is perfect. Then TE is done to see all the gradients of pulmonary vein and pulmonary artery and the RV function. PA pressure should be 1/3 of the systemic, low FiO2 requirement in the ventilator 35 to 40, PF ratio preferably more than 200, and then protamine to give slowly and check for ABG a repeat. So the meta-analysis of ECMO versus CPB, it has been shown that ICU's length was shorter in the ECMO group. And one more study which showed that lower rate of PGD bleeding and ICU stay and mean hospital stay was better with intra-op VA ECMO usage. So next is indication immediate post-op. So immediate post-op indication of ECMO is primary graft dysfunction. So what are the cause primary graft dysfunction? Etiology, it may be recipient, donor, or the post-op factors. Recipient is the patient with having RV dysfunction pre-op, severe PAH, chances of having PGD. Post-op donor like marginal donor, prolonged ischemia. Younger donors, very small, 15, 16 years, have less immature lung, which leads to higher chance of PGD post-op. And I think next case, the discussion also, there is a PGD, so we'll not go detail in this. So this is our experience, outcome of ECMO as a bridge to lung transplant. So we have seen that ECMO as a bridge to lung transplant is a option which we can use it and has shown good results. So in conclusion, ECMO requires a comprehensive team approach. ECMO is a viable option for selected pre-lung transplant candidates. Central VA ECMO is preferable over CP bypass for intra-op support. Outcomes for ECMO as a bridge to lung transplant can be comparable to a non-ECMO lung transplant patient. Thank you. Shall I continue with the case presentation and then discussion, or yeah? So this is one of the case which we got, I think, 2-3 months back. 3.5 months back. 74-year-old male, known case of ILD on continuous oxygen. He was in other side of the city. So I had an ILD examination, was admitted in an outside hospital in July 23. He was tried on HFNC, NIV, and then went on ventilation. He had a high carbon dioxide, I think more than 100. And then, so they went to put on a VV ECMO on August of this year, 18th August. So patient was on sedation, paralysis, and was not responding according to that hospital doctor. He was on ECMO and ventilator and on vasoconstrictors and was asked to come to our center. So he was seeing us before also. He had seen our pulmonologist before. So they wanted to come to us. So the risk was explained and brought to our hospital. CT was done the next day on the 20th. So showed bilateral basal ganglia bleed, small bleeds in the sulcal subarachnoid hemorrhage, left temporoparietal bleed. So he had multiple areas of bleed in the brain. So that is the reason. And normally what happens in here is whenever the patient comes for us at ECMO, they are already sedated, paralyzed. The ECMO team or the ICU team there never, in all our places, they never stop the sedation. The patient is on high. They worry that when they stop sedation, saturation comes to 90, and we are worried that he will have other problems. So most of the centers here do it. So that's what I'm saying. Whenever patient is on an ECMO, please try stop sedation, try mobilize. So we are not putting a patient on a machine to send him home on a machine. So we want him awake, mobilized as much as possible. So if we don't mobilize him, there are no chance of his lung recovery because he is not, after sedate paralysis, he will not breathe back. And if we can't do any transplant or anything on him. So as awake as possible is what is to be done. So then we told the family that he had neuro issues. So what we did, we stopped the heparin completely, stopped all sedation, and started other physiotherapy for him. And on the second thing, why I put this case is patient who are on very high CO2. Like he had hypercarbia, like 100, 120. You start an ECMO and sweep of 4-5 liters. The CO2 falls from 100 to 30 in next 1 ABG. That is in 20 minutes. So when there is high CO2 change in the brain will bleed. So I think this is what happened to this patient. So avoid ECMO to start off with. A very patient on a high ECMO, you should go or slowly on the sweep. Sweep should go 500 ml, 1 liter. CO2 should be brought 120 to 100 slowly over next 24 to 48 hours. The CO2 should not fall drastically. So this is why I put this case. Second, so what we did, we stopped all heparin, no anticoagulation. We stopped him, no sedation. So then he started responding to commands. On the 22nd of the August, he was responding to commands and he was moving all limbs. So we activated him now for the transplant again. The family was counseled that he has chances of bleed, stroke, and post-op he may have a stroke, he may have a bleed. And intra-op also, when we put on a VA ECMO, we have to give heparin that time, he may have bleed. So we counseled them. They agreed for next 7-8 days. When he was waiting, there was no heparin. So this is one more thing. Patient during COVID time, we run on heparin. We do a tracheostomy. He bleeds for 10 days. We can't stop. So we put a drain. We bleed for 8 days, and then patient is not there. So in these cases, if you stop heparin, watch the circuit for clots. You can change the circuit, but patient should be alive to do a surgery or to make him so bleeding should be controlled, avoid completely, because if he had started on heparin him, he would have bleed more. So we stopped that. Then on the 26th of the August, he received an size match organ. We could wean him of ECMO on the intra only. And then post-op was little stormy. He had melena and I think CMV in the bowel. And he had the DVT because of the ECMO. And we had to put an MVC filter. He had tremors because of the age and Parkinson. But still we could discharge him on after 2 months, that is on October. Now the patient is 3 months post-transplant and he is doing fine.
That's a valiant effort. I'm sure everyone who has touched this patient feels so rewarded by the care you have delivered. And he's alive, he's home, he's doing good. So 2 questions. If you had a similar patient again, apart from what you have told us, what would you do different? 1. Two, was the patient ever off the ventilator when he was on ECMO?
No, he was not on. We did a tracheostomy, I think, on the the day we received him, 21 day later. So he was off the sedation, but on the tracheostomy on the ventilator with the ECMO.
And he was on positive pressure ventilation.
Yes, yes.
So there was never an intention for recovery of the ARDS then?
No, he was an ILD.
Oh, sorry.
Yeah, he was an ILD.
And what would you do different?
I think
You must have learned something for 4 months of care that you have delivered.
as I said, avoid the sweep decreasing physiotherapy, and this is something which we do.
I think probably the point that he brought about sweep gas while you initiate ECMO, I think is a very important point. I
Yes.
think we must congratulate him for that.
Yeah, he did. That's a real point.
Yeah,
I think you should start at half-liter sweep when you put it, and then slowly go up.
Yeah, we actually learned it the hard way, Arish, because we saw this very frequently, and probably Vijil and Urmil and even Pawan could tell us more about it. We learned this during COVID, and we've almost always noticed that when we had remote, kind of transfers where patients have been initiated on ECMO outside, and this is what they do. They just kind of jump the sweep up to 5 liters. We've seen young physicians turn up during COVID brain dead. ECMO initiated outside simply because of an improper, kind of methodology for ECMO institution. Pawan, would you like to elaborate a little bit?
I think we have a few vendors who can initiate ECMO offsite, the different place, and then can shift the patients to our hospitals. And not everybody have a similar level of training. So that's when we have seen this happening. And also when we receive the patients, and also the ECMO equipments are a little different, and also some people get confused maybe there as well. And yeah, this is definitely a major problem. And also when they're transporting, maybe they don't have continuous monitoring and frequent access to the ABG as well. So these are the challenges probably. Yeah.
Other thing is most of them sedate the patients too much, and paralytics, and then there'll be infection. They'll be mostly on polymyxins or colistins. So majority of patients come to us with severe critical illness neuropathy, and this really hampers the progress post-transplant because muscle power is quite poor, and then it delays their recovery to great extent. So that is the challenge.
Normally we do in this one double cannula only, but in some cases who are not requiring so much support, we do the Avalon thing, that's a single cannula. ILD is not so high with
So my question is to Dr. Vijay. I'm from Medanta. So what is the optimal time period in ARDS ECMO patient? When should we consider patient for bridging to transplantation? What is the optimal time window? Because if we do early, we are not giving them enough chance to recover. If we are doing too late, there are chances of infection, especially in an Indian scenario. What is your take, sir?
But it depends. You have to follow them. If there is any improvement happening, maybe we can wait more. But in Indian setting, it's like another resistant bug is in the corner, right?
Yes, sir. Yes, sir.
So it's like a wave of infection. You get first Acinidote, Pseudomonas, then you get Sphingommonas, you get other breakthrough infections, Elizabeth King. So you have to balance it out. There's no clear-cut answer for it, but a minimum period you have to wait. You see if there's any improvement in the compliance, any increase in tidal volumes, any decrease in CO2 happening without too much of ECMO
So minimum
support.
wait period will be 4 to 6 weeks.
Yes, yeah, it may be more, but minimum.
Minimum.
Yeah.
In this case, we used to monitor the ACT and we didn't give anything. We just monitor the clots, any clots are happening or anything. So if the patient had clots, we may had to change the circuit. Yeah, that's what we have done. Yeah, one more thing is we kept it at more flows. So the lower the floor, lower the chances of a clot. So we meant at full 4.5, 5 liters.
You
of
mean
flow.
higher the chances of
Yeah.
clot?
We will transfer. We will transfer.
So to answer to your first question also, I mean, also it depends upon the etiology. Now, if you have an ILD, which is going into an ARDS in a patient, you would transplant much early on. If you are a COVID ARDS or any other viral pneumonia going into ARDS, you would definitely bridge to recovery first and see how it works. And then you take a call. So, I mean, when the COVID came, the Toronto group published the guidelines or the indications for COVID ARDS, but they did not mention about that 4 to 6 weeks caveat was from the initial sign of radiological, irreversibility. It did not mention anything about the ECMO. So when we published our data of 23 COVID lung transplants in transplantation proceedings, we specifically I mentioned the point that from the Asian settings, it has to be, we cannot just ape the Western data and say it's going to be 6 weeks. I'm talking just about the COVID or the pure viral pneumonia. I think it would be from case to case basis. But as Vijay sir told, that at least give some time for the lung to recover. Do not transplant early on if it's just a viral pneumonia or a COVID which is going into ARDS. We need to bridge to recovery first and then take a call.
COVID is more likely to recover. H1N1 and H3N2 may not be as. So it all depends.
So the other thing was any irrevocable airway, lung complication like a massive pneumohemothorax, persistent drainage. Obviously, I think the 6-week window period doesn't count there. You just have to proceed because you know that lung is never going to recover. And sir, for you, I think large bore cannulas, short tubings, minimum connectors, and high flows, especially in a setting where we do not heparinize. And Anup, if you can talk about alternatives to heparin.
Yeah, we are using bivalirudin nowadays for.
So we routinely use bivalve for all our patients now on ECMO. We have stopped using heparin, probably 2 years now.
Yeah, nearly 2 years.
2 years now. We changed during COVID, and we've continued to use bivalve.
The issues are.
Yeah, definitely.
So the issues are that platelets comes down. We are worried that it is because of HIT or second infection leads to low platelet. So circuit also consumes the platelet. So, but we are worried so many issues are there. Second issue, the bleeding in post-op, immediate intra-op, post-op, with heparin was higher. When we changed that to bivalirudin, so we found that intra-op, when we stop off the bivalirudin, in 1 or 2 hours, the surgical fluid is clear. And that helps us recover the ECMO patients going on lung transplant. Second, as you know that platelet hit we avoided. So these are the 2-3 things which made us change to bivalirudin and avoid heparin. So.
Anyone else?
Usually we keep an ACT of 180 to 10 seconds.
In VV ECMO, 160 to 180 is enough.
So what is the minimum ACT acceptable? Like in this patient?
In this patient, it was around 150 also. We expect we didn't start it. It was around 150, 145 also. We didn't start.
Sometimes platelets are low, INR is more.
Yeah.
It's not a matter of maintaining ACT.
Actually, he was lucky. He got in 8 days. So by the 8 days, we didn't change a circuit. We were thinking he may require a circuit change around the 8th or 9th day because the clots were started forming, and he got an organ.
Yeah, one more thing. Suppose patient has INR say 2.5, 2.8.
Then
what is there Your protocol to correct that with FFP, vitamin K.
You are asking for the interop or patient is already on ECMO. We normally correct all the so we target a platelet of 40,000 above. If less than 40, we transfuse it off. If patient is having INR high, if fibrinogen is low or if INR is high, if fibrinogen, we give fibrinogen available or we give a cryo. Or if the INR is high, we correct it with the FFP. So not like 1.5 target. We target around 2 of INR, platelet of 40,000. So in these patients, yes, because we had to stop the anticoagulation. He had an IC bleed. If INR is 3 and he'll bleed more. So we can't target an INR of 1.5 1 in it, but not a 0, not like 3 also. So we'll correct it to a page where we can manage the.
Any catheter or circuit related problems which you have seen during mobilization or awake ECMO?
That's
because
why
it's one of
we had one patient whose cannula had come out. So this can happen. So that's why whenever first fixation is very important. So we fix here, we fix with a headband and holster. And during the mobilization time, the critical intensivist, the physio, the perfusionist, and the ICU staff, all 5 are there, all 4 are there. So that is there. So we had one case of. Yeah. Yeah, the most common problem is when they walking, the chances of kinking are there. So that's why the perfusionist should be there. He sees there is a fall in the flow. So we should know. One maybe because of hypotension as such, but second problem will be there some clamp is checked or the cannula is kinked somewhere. Sometimes during mobilization they clamp to the bed, and then they when we mobilize the bed is it gets kinked there, and we think the flow is slow. That's why I said the perfusionist, the ICU staff, OT, and doctor all should be there to when you.
you stop the process and
Yeah, we stop the process, check the cannula, check the sites.
So you prefer access and return cannula same site or different sites?
Whichever available. Sometimes there is DVT, sometimes whatever. But what we normally put one femoral vein to take and give it back to IG.
Yeah, I have one question. So mostly we get the ILD with the RV dysfunction, and on the bridge we put on the ECMO. Was the point where we think that now he's candidate for the lung transplant alone, or maybe the heart lung transplant? Because the once in the on ECMO, then how do you define it with what's the criteria where we are fitting into the lung alone or going for the should be a candidate for the heart lung?
Two things. What will happen here? The patient who is already an ILD, they will have a PAH. PA pressures will be high. So when the PA pressures are already high, the chances of RV dysfunction are already there. Once they went, what happens is they are having hypoxia, hypercarbia, acidosis, which also leads to high PVR, which also leads to further RV dysfunction. So these all can be managed once the new lung is come. So if your LV is fine and your pre-evaluation you feel the LV is fine, RV there are issues, but this can be managed immediate post-op by keeping him few days on a VV ECMO or a VA ECMO immediate post-op. So, but if overall the coronaries are fine and everything, then we prefer to do only a lung transplant.
So, I mean, will you want to look at the TAPSE or the RV thickness in these patients because they cannot be shifted to the once patient is on ECMO, it cannot be shifted to the I mean for MRI cardiac.
Yeah.
So, we'll be looking at the TAPSE alone, or is there something else we can do in these patients?
We normally see only the TAPSE and the heart function as such. So, but other than that, any inotrope requirement in the ECMO during that time. So this all tells the heart may be going to have a problem. But a patient who is running on a VB ECMO as such will have an RV dilated because all the 5 liters or 4 liters whatever flow you are pushing on only on the single side. So there will be a dilated RA RV, but we have normally go with the only lung transplant.
So, what's the choice of ECMO in patient with the definitive RV failure? Is it VA ECMO, VV ECMO, or VVA ECMO, or the?
There is no exact cause for treatment for each thing, but if the RV is completely gone, then we have to put a peripheral first, go for a peripheral VA, then stabilize him, then shift to a central VA, or depending on what you want to do for him, that only lung transplant or bilateral only heart and lung transplant. So depending on that, we have to change that.
So let's say you had on the VA ECMO or VV ECMO, and we transport patient to the theater, and we did the central transport patient to the central ECMO. Now, once the surgery is over, obviously the RV is not going to recover in the 6 hours, 8 hours. It will take longer time, and we have to put again on the ECMO. So will you change the?
If it is already central ECMO, we shift to the back to the ICU on a central ECMO for next 2 to 3 days. Once we will be serial T'ing the transthoracic or a TE echo, shift to ICU OT again, check whether the lungs are fine. If the lungs are fine, then and the heart are improved, we can remove it, or use the option of chest closure axillary with a venous drainage, close of the chest, axillary, take it out as a, it's like a central, but not through the chest, but through the axillary, and taking from the femoral, giving through axillary artery. That's like an ECMO VA ECMO. Wait for next through 3 days more, and then mobilize him out of bed, physio, do continue all the things, and then when the Harvey has recovered, remove it.
Okay, I mean, what my question was that will you able to take out the catheter in with the peripheral catheter once you put patient on the central ECMO?
So we'll be using the venous already from the peripheral only. So we will not put the venous here. Only the aorta will be here. Yeah. So patient was on pre-op VV ECMO. We put femoral vein is there, and central artery we are using it.
So one more thing to answer your question. You were asking when the patient is on a VV ECMO, how do you assess the RV? So I know it's not easy to do a cardiac MRI, and echo will not give you much information on that one. So basically, what we have seen when we start them on a VV ECMO, if your RV doesn't do well, you will fail there itself. You cannot maintain the flows. As you increase the flows, RV will dilate. You can't run the ECMO itself. The patient is going to fail. And in those cases, go up. There is no flow. You don't get blood into the LV. So there only you will end up failing. So we'll have to convert it to a VA ECMO. If your patient is holding well for 10 days or 15 days on a VV ECMO, that means that RV is going to do well. This is one thing that you have learned.
Yes.
Harish, would you like to add to this exciting conversation? Anyone else in the room?
I think the RV will recover soon unless you have a lot of fluid status issues. So that's why you're waiting 2 to 3 days. One key point that we keep missing it often, CVP. What's your CVP? You will always have problems with the RV if the CVP is more than 20. That's my golden number. 25, 20, 25, RV is going to struggle. But if your CVP is less than 20, then the RV will fly. It doesn't matter. Lung only. Are you on ECMO or are you not on ECMO? Not an ECMO. Okay, now that's a different discussion. Yes, you can do cardiac MRI and look for RVEF or less than 10%, then probably your RV will struggle.
So with the cardiac MRI, tell us whether there is a structural problem in the RV myocardium.
What you're saying is there is so much remodeling happened that are already, and the RV will struggle if you just do lungs.
So if this fibrosis set in, or what is the percentage or the numbers that on cardiac MRI that you will decide whether this RV is not going to recover post lungs?
Right. So RVEF less than 50% and RV with gadolinium showing a lot of streakiness of more than 50% of the RV. We used to think this RV is bad and we need a heart lung. And there are 3 other parameters. But because of the change in allocation, where the hearts take precedence over heart lungs, we have to resort to lungs only. What we have seen No matter how bad the RV is in whatever testing we did, RV recovers unless your CVP is more than 25. Then that RV is not going to recover.
So that can always be optimized.
How much will you? Already the patient is hypertensive.
And unless he has a bad TR or his volume, it's not going to be volume loaded per se. The TR can cause the high CVP.
TR can cause high CVP, true. But if your CVP is more than 25 because of RV failure, that RV may struggle.
I think we should also look at the reflection of the status of the RV on secondary organs. That will probably give you a better understanding of whether this RV will recover. So transaminases are persistently high. Bilirubin is not tanking as you would expect.
Even the hepatic venous flow patterns and the portal pressure,
I don't think we go there. But yeah, no, I mean, it's difficult to assess that.
Early on to see whether
There's congestive hepatopathy in every RV dysfunction. That shouldn't guide you one way or the other.
I think Harish, we have ways and means of handling this RV post-op. And would you consider a Nova lung kind of a circuit in the post-op to decompress? I mean, that's another question. Would you, if you want to use?
I mean, you're talking about really, really dire circumstances. What will you do? Hail Mary trials, like whatever. If I do one thing, it works, and I'll say it worked for me. But as a general rule, you want to avoid any further intervention and support the patient, wait for the RV to recover.
So we'd always do long-term VA ECMO. Would it be central, peripheral?
Any support. I mean, depending on your convenience, are you closing chest, not closing chest, you have infection, not infection, whatever. You just support RV recovery. My favorite.
Yeah, I mean it's off-label in India, but it's very expensive. That's the other challenge. And I guess using it is not.
For pulmonary hypertension or any RV dysfunction, we prefer our VV ECMO support is preferentially protect. One cannula stays there, liberate ventilator, ambulate the patient. It works phenomenally well. No RV dysfunction. You will always have a clot at the distal tip of the catheter. So after the transplant, you have to be cautious taking out the catheter. And the Protect DO works great.
It's off-label. So what about sport VA?
What do you mean sport VA?
Auxiliary IJV.
Oh, that's fine. That's a decent cannulation for any intervention. Nova lung, when we would do Nova lung, when the RV is severely dilated, it's not recovering. So you can just decompress that and perfuse it back to the PV or any of the left side. And you just aim for 1 or 2 days. That's it. And it will fly.
Yeah, that was exactly what I was coming to. Suppose you have this RV issue post-operatively. You could probably allow the LV to fill with this circuit. You could decompress the deconditioned RV and it would probably give it time. Because we have one such case right now, and there was always a toss-up between what we would do. It was a girl that underwent a double lung probably 4 days ago, and she had sarcoid, severe PAH. Post-operatively, though it was a size-matched graft, I think she had a lot of PGD. We went on VV ECMO post-operatively. She continues to be on VV ECMO. She's on CRRT too right now. And the question when we were planning to close chest was, should we switch to VA now that the LV wasn't filling at all? It's just today that the LV now shows some signs of filling up after 6 days.
Yeah.
So if it was IPH, we would have seriously thought about this option, but it was sarcoid. So we, gave it a benefit of doubt. We thought that probably it would settle in a day or two. It took 5 days, but it's taken her down. Hopefully she'll recover because she's very young.
Yeah.
So
I mean, if you have any issue, it's prudent to go early than waiting to make the decision at day 5. What we have learned is if you have RV dysfunction, LV not filling, prudent to decompress and flow the left side early on, because that's a much simpler, easier, prudent, more better hemodynamic support. Save the organs, no CRRT. Maybe she'll start putting out urine by herself. So all the interventions have to be timed. It's always like that. You feel in the OR, it's good, everybody is fine, and you go. Those assessments, if in doubt, fix it before you leave.
Okay, so we break for 10 minutes for tea and then we come back. We continue? Fine.
He can come here too.
He cannot walk. Okay, so fine. So if we go, fine, yeah, okay, 5 minutes and we'll be back.
Hi, Niranjan. How are you doing? You're not late, Niranjan. Yeah, you look great. Yeah, you looking great. I just couldn't recognize you. Tennis elbow also. Come. It jumps up. Conversation between friends. Yes.
So welcome back everyone. So in the morning pre-tree sessions, we have seen pre-op things like donor and recipient selection and ECMO bridging to lung transplantation. And in the following sessions, now we'll see complications post-lung transplantation, airway complications, and infectious complications post-transplantation. So I would invite Dr. Harish Sitam Raju to take the proceedings further. Thank you.
No, it's fine. Move it here. I got it. Thank you. Well, I'm glad to be here. Thanks for the invitation. And the morning interactions are pretty collaborative and very interesting interactions. And I was given this topic, complications post-lung transplantation. But this is followed by airway and infectious complications. But I'm going to touch on some of the unique aspects of lung transplant and how post-op care and due attention to the different aspects and putting the physiology of the post-transplant lung into perspective. And hopefully this should throw some light on the unique features of lung transplantation. It is a multi-system disorder. One would think that happens because the lung failed or we put a bad lung, but patients can die because of other non-pulmonary complications post-transplant. These are the number of big transplants being done. US, probably about 3,000 transplants per year. And complications, medical, surgical, some of the pre-existing conditions can be unmasked after a lung transplant. And we'll talk a few about that. This is a usual transplant, nice donor allograft, recipient surgery, explant, implant, very rewarding. I wanted a picture of the video of the transplant that was done last night, but I don't have it. But I wanted to put that here too. Complications are multi-system disorders. Early on, surgical complications and infections are the most common cause of death universally, not just in one continent or another, are the most common cause of death in the first 30 days post-transplant. Bleeding in the chest tubes may not be apparent because most of those tubes are moving and there may be a lot of clot sitting right behind the lung. So a clinical assessment is always important, especially in the ICU. Sternal dehiscence causing flail chest. The common issue here, especially when you leave the chest open for a couple of days and then you close, the chances this can happen are a little higher, especially when the patient gets extubated and you're trying to ambulate the patient. Torsions, pleural effusions, airway dehiscence, and pericardial tamponade. Diaphragmatic dysfunction, unrecognized. Very usually you end up doing tracheostomy when the patient cannot be weaned or extubated. But diaphragmatic dysfunction is a significant factor post-lung transplant, accounting for morbidity and complications. I'm going to talk about pulmonary complications unique to transplant. PGD, graded by severity of gas exchange deficits, grade 1 to 3. And risk, the things one need to exclude during this, before a diagnosis is made, are arterial anastomotic and venous anastomotic obstruction and infections and any other, if the chest is open or any hemorrhage happening. So if they are excluded, and I don't know how one can exclude a trolley in a post-transplant phase as a cause of acute hypoxic respiratory failure. But if the patient's condition acutely changes, especially after a platelet transfusion, we have seen that trolley, because of platelet transfusion, can happen. So we typically tend to avoid platelet transfusions in the early post-transplant phase. Recipient risk factors where PGD is expected. Diagnosis of sarcoidosis, pulmonary fibrosis, and pre-existing pulmonary hypertension. Pre-existing autoantibodies, patients on ECMO requiring multiple transfusions, mechanical ventilation, and obesity. What are the factors one would do to avoid PGD? Trying to maintain the cold preservation until the transplant and keeping the warm ischemic time once the lung is out to as minimum as possible. When you perfuse the pulmonary artery, the oxygenation should be on room air or max at 50% FiO2, slow pulmonary artery clamp release, limit platelet and PRBC transfusion, and if any suspicion, early extracorporeal support. Once PGD is diagnosed, lung protective ventilation, ECMO, nitric oxide, inverse ratio, and PEEP are the usual strategies. So this is a unique concept people are entertaining, as in after PGD, the lung is inflamed and you're spilling a lot of cytokines. One may use the ECLS systems one has, take out the lungs, let the lung cool off for a day or two on the system that one has, and then reimplant them. So this is a patient with immediate post-lung transplant. Everyone thought patient has PGD, but she had some pre-existing antibodies. So you can see the VV ECMO cannula, instituted intra-op, and the chest is closed here. And we did a biopsy showing neutrophilic capillaritis. Early post-transplant biopsy on a patient on VV ECMO with nitric oxide. So we ended up giving aggressive anti-B cell therapies, and with eculizumab, the first ever use in a human lung transplant. And the patient remarkably improves and starts making urine as soon as the alloimmune damage is reversed. As in, the point of this case is always we have to make an attempt to diagnose what was the underlying reason for PGD and address the underlying problem. But we can't label every patient with bilateral infiltrates as PGD. Aspiration pneumonia, either from donor or recipient, are real. And a contusion or a PE, which was undiagnosed in the donor, can present as an acute infiltrate or severe hypoxemia. Infections, especially prophylaxis, from the donor or the recipient. Early on, herpes virus seems to be very common if you're not on prophylaxis. Universally, every patient will develop herpes infection if we are not prophylaxing them with any of the antiviral therapies. Pulmonary embolisms can be donor or recipient driven, and most PEs go to, if you do a single lung transplant, most PEs go to the transplant allograft invariably. And risk factors are as identified. This is a patient who had a lung transplant and had acute cardiac arrest, went on VA ECMO. To diagnose why he had an acute cardiac arrest, we investigated his coronaries first, and the coronaries were clean. And then we investigated the pulmonary artery and pulmonary vein, and we saw there was no perfusion in the lower lobe. Catheter-based clot extraction, and with restoring perfusion immediately, and able to liberate the patient of VS ECMO. This is another patient who had PGD, recovered, fantastic, went home, came back with exertional hypoxemia. I don't think this is showing up. There is a small aberrancy in the venous phase in the left atrium. Most radiologists I spoke to said this is just an artifact. But because of the exertional hypoxemia, we did a TEE showing a PV clot from the left lower PV freely moving. 2 days later, she developed a stroke. PV complications can be immediate post-op or can present afterwards. This is primarily because the endothelium and the venous anastomotic site can be exposed, being very thrombogenic, and can lead to clots. Or she's fortunate, she could have thrown the clot and she would have died in the middle of night, and we would have blamed it on some cardiac arrest, and we wouldn't even know this would have happened. Pleural diseases can be a significant comorbidity. It can be a reason for a rejection, lymphocytic exudative effusion with normal glucose. Most effusions need to be treated. If we leave the effusions, you may end up in a trapped lung physiology or a restrictive allograft dysfunction. This is a patient with a single lung transplant who goes into respiratory distress. This is the transplant lung, doing great, and suddenly develops respiratory distress. My ICU team immediately intubates because patient is in distress and got extubated 2 days ago. But after intubation, patient is still hypoxic and PCO2 is going up. So, and then they add PEEP, and now he is hypotensive and on multiple pressors. The native lung hyperinflation, compressing, and the mediastinum. These things are subtle and not too evident, but knowing what has happened in the last 1 hour, one should have picked it up. And what we did was we changed it out to a double lumen tube, and immediately patient recovers. The cause of hypoxemia was a simple mucus plug, which could have been taken out by a bronchoscopy. Not every hypoxic event need to be responded with an intervention that we are usually used to by intubating ECMO and other things, and it can actually cause more harm than any good. Another patient, my team called this is a PGD unfolding. It can be unilateral, it can be focal. This is PGD unfolding. And here the patient's and PCO2 was going up. And this is the post X-ray. When the X-ray was done 1 hour before this event happened, it was clean. 1 hour later, patient got hypotensive and end-tidal CO2, and this is a segmental infiltrate. And this is a lobar torsion, and identified by bronchoscopy, and emergent surgical intervention restores the lobe. Typically, we end up putting some clips to the chest wall and stabilizing the mediastinum to help prevent this complication. If you have not seen this, it's going to happen to you. Invariably, it happened to every one of us in our careers. And some patients, some of the times it's recognized late, and you end up doing a lobectomy on those if not recognized in a timely manner. Airway complications are real, airway dehiscence. I think the next speaker is going to talk more about it, and I shared my thoughts on surgical, how a surgery accounts for most of these complications, no matter how best we match the size. One thing I pointed out yesterday and today, when you close the, when you do your first bronch, the length of the suture line is something one needs to pay attention. And when you bronch again, if that amount of visible suture line is increasing, that's a dehiscence waiting to happen. So before something like this happens, one should try to intervene and stent, limit the complication, diagnose the infection, so to prevent something like this, as in stabilizing the anastomosis. Most of these anastomosis can be recovered by endoscopic procedures. It's okay to end up with this than trying to do a complete 14 mm, 12 mm. We prefer granulation to happen and narrow down the anastomosis a little bit. So this can be easily intervened after the first 3 months. But if we tend to oversize these stents, this ischemic complication has only one way to go, distally, and that one would lose the graft. A vanishing bronchus syndrome, if you have not seen, it will happen to you one of these days. And in the past, all our surgeons did prefer to do a pneumonectomy. but because of the interventions that we have today, we are able to do sequential dilation. And now and then, every year, I get a referral from other transplant programs to open up an airway where there is no pathway for this. So we do a CAT scan, see the potential pathway, where to go, and poke around, try to find a passage, and balloon open salvage the airway. Vascular complications, pulmonary artery stenosis, vein stenosis, and pulmonary embolism are real. And this is a patient with left PA anastomotic narrowing. So initially the radiologist says, no, the contrast is flowing fine. There is no kink, there is no narrowing. So we had to prove this by doing an arteriogram and show the gradient and look at the thin strand. Yes, the contrast is flowing. There is no obstruction, but there is a gradient across a vein of 20 mm. Ended up getting a stent with improvement in. These things can happen on the right side, left side, doesn't matter, PA size. Every donor PA is much smaller than the recipient PA. So there is a size mismatch. And sometimes these things happen to the best of the surgeons. And these things need to be recognized early so things can be fixed, so the patients can have a great outcome after transplant. So I'm moving from lung to the heart. And the heart is an important organ, and we cut the PA, the main outflow of the RV, and we cut the main inlet to the LA, the pulmonary vein, and we put two anastomoses together. In that event, a lot of things can go wrong. For example, as Dr. Attawar was pointing out, this is a patient who had a left lung transplant, has PGD, we put on ECMO, and we decided this lung is dead. And we ended up retransplanting. And when we took out the lung, this is what we found. The whole pulmonary veins got thrombosed. Again, this is not done by a young surgeon. The surgeon whom I'm working with has been done about 1,000 transplants by this time. And even to the best of the best surgeons, these things can happen. And if recognized early, the patients can be bridged to a new lung to help them survive. With persistent pulmonary edema, failure to extubate, a patient developed an MR, which was a mild MR pre-transplant on the TEE. Now, post-transplant, because of the change in the anatomy or the increased flow on the left side, the MR showed up to be clinically significant, presenting as unilateral edema. And we failure to extubate the patient. Whenever you wean the sedation, she develops this infiltrate. Found out it is not the lung, it is not the donor, it is the heart, and the MR was much worse. Ended up getting a mitral repair by the great Dr. Adams, and the patient did remarkably well. Another patient with hypoxemia, a nice case. I think I shared this before too, and it has been published. And often you end up seeing such cases again. Once you see this and you will keep looking for it, you'll find more of these. Hypoxemia post-transplant, that's the lung allograft, looks great. Only when he sits up and ambulates, his oxygen, he desaturates. When he's lying down, he looks great. So we did a TEE to prove that he has a new onset right to left shunt because of the rotation of the mediastinum. You can open the PFO and make the shunt worse. And this ended up getting a Amplacer device closure and fixing the hypoxemia, and patient did remarkably well. Pericardial constriction, because of the extensive dissection, it happens. This can be real. Cardiac MRI, people were pointing out. And this can be utilized to make the diagnosis of a constrictive pericarditis post-transplant. Key here is one has to do a total pericardectomy unless you go behind the left atrium and clean it up. the patient will not have a relief from the symptoms. So another major surgery for him. This is a patient with persistent edema post-transplant, a new pericardial cyst compressing on the venous drainage into the left atrium post-transplant, ended up getting a surgery debridement with relief of symptoms. Pulmonary vein stenosis, and using advanced CT scans showing that the contrast is flowing, there is no problem, but look at the vein, it is attached by a thin thread. And this patient ended up getting a pediatric coronary stent, presents as persistent left lower lobe edema, and with the PV stent, it improves dramatically. Hemoptysis. So post-transplant hemoptysis is can happen. The point I wanted to make on this is the vessels can be coming from anywhere. In this patient, we investigated all the intercostals. There was no flush. But when we went below the diaphragm, the phrenic and the superior phrenic was the one that's feeding into the lung. That was the reason for hemoptysis. So this aberrant arteries can come from 5 main dangerous territories. From the aortic sinus, I don't know why, but the RCA, the vessels from below the diaphragm, intercostals, and from the left circumflex. Patients cough up blood, had chest pain, and died when VTAC arrest. Patient had an aberrant vessel feeding into the left circ, and we tried to intervene, and we knocked off the circ. Gastrointestinal complications can be life-threatening, and C. diff colitis. We lost a couple of patients because of C. diff colitis. And when patients develop diverticulitis and perforation, their clinical signs of peritonitis are absent. Abdomen is soft, there is no evidence of any rigidity, guarding, tension, and you open the belly, there is feces all over the peritoneum. And these gallstones, if you leave it alone, is going to cause problems with cholangitis and severe sepsis, and that needs to be taken care of. Gastric infections, especially when we are using tremendous immune suppression pre-transplant to control the interstitial lung diseases, unique complications driving the GI system leading to mortality can be real. This is my recent patient. Patient came with abdominal pain. My ER doc ordered a CAT scan, and this is the CAT scan. The surgery team saw the patient, took the patient to the OR. And before they operated, the anesthetist called me and they said, "Hey, is there anything you want me to do with immune suppression before we operate?" And this is pneumatosis coli. It can happen, and we don't know why it happens. It will be very, very dramatic CAT scan, but the patient looks absolutely silent. We asked to wheel the patient back to her room, and we didn't do anything, and all these things will resolve. So learning point, don't treat images, don't treat CAT scans. You have to put it into perspective of what's happening with the patient. Renal etheroemboli, patient is doing fine, and suddenly urine output drops. And renal etheroemboli during anastomosis, we entrain a lot of dirt from the lung that we transplant, and it goes into the left atrium. And that could be the reason for AKI ATN. Typically presents with polyuria initially, excellent urine output, and everyone is happy that the urine output is so good, and all of a sudden they shut down. And you do a renal biopsy, you would see infarcted kidneys all over. Neurological complications, metabolic encephalopathy, hyperammonemia, secondary to urease producing organism. Most common in US is urea plasma. There are many other urease-producing organisms that can drive hyperammonemia. And tacrolimus-related seizures, cerebrovascular accidents, and PRES without high blood pressure is a common side effect of calcineurin, prograph, and ophthalmoplegia and optic neuritis, causing blindness secondary to immune suppression. These are the unique neurological complications post-transplant. Patient was deemed having multiple strokes and brain death. They're trying to talk about end-of-life care based on an image. And this is actually a common side effect, PRES, and you stop the offending agent, they remarkably wake up in few days. And basically there is no treatment for it. But if you're looking at an image and a young radiologist is going to call you and say he has multiple strokes and this is not survivable. Infections are the most common cause of death. I'm going to only touch on some unique. Cytomegalovirus is the most common viral infections we see, and these symptoms are absolutely silent. Normally, we track CMV PCR in this blood to diagnose this, but in fact, the CMV PCR can be absolutely normal with severe colitis, retinitis, and the blood PCR may be absolutely normal. And this has been described in liver transplant literature too. So tracking putting a patient's clinical findings and trying to identify CMV as etiology by a biopsy is relevant. Multiple treatments are available today, but previously the only treatment we had was ganciclovir. Viral infections, I would like to point out two of them. Multiple transfusions in the donor or during the transplant surgery. HTLV can be a transmitted infection. And most of the blood products that we use when you are doing blood transfusions, they may not go through the extended screening, and patients may present with spastic neuropathy. And we have given COVID to patients from donors who have absolutely BAL PCR negative, but we transplanted and the patients had COVID on day 1 post-transplant. So infections can be a significant comorbidity. A patient presents with a mass lesion and everyone thought it was cancer. We did a biopsy. This is nocardia, and you treat it effectively and this disappears. Patient presents with persistent fevers, not knowing in a heart-lung transplant, and a myocardic aneurysm of a BAL showing Candida tropicalis was the only one that we identified. And patient had throbbing headaches, hypertension, and fevers, diagnosed by an MRA, and ended up having a resection with a Dacron graft. And she is a transplant Olympic swimmer. So she wins gold medals in transplant Olympics. And for the last 10 years, she's still doing well. Fortunately, she got married. She has a kid now. Hematological complications accounting for life-threatening diseases are TTP, HUS. Previously, I was told you need to do a biopsy to diagnose it, either a kidney biopsy or have a hematologist do extensive testing to make an appropriate diagnosis. But what I have learned recently is you can diagnose HUS-TTP by a simple skin biopsy and looking for the complement fixation in the skin. And that can be diagnosed by a skin biopsy and appropriately treated. Bone disease can be extremely limiting, especially vertebral fractures. Few things I wanted to identify are voriconazole as an antifungal drug that we normally use can cause severe periostitis and bone inflammation. And on a bone scan, if one tends to do a bone scan, it looks like a metastatic disease. And this is just voriconazole causing a complication. Unexplained dyspnea in a post-transplant patient with diffuse infiltrates. Patient was on sirolimus. We stopped that, and those things resolved. So drug-related complications causing in drug-induced lung diseases can still be seen. And nitrofurantoin, amiodarone, all these things that we commonly use can cause serious complications in the lung. That's my last slide. Thank you for your time. Case discussion or question?
Set it up. I have a question. Had a patient recently loss of vision or reducing vision post-transplant. How do you? And there was no MRI, really nothing, no infarct, no retinal obstruction.
Confirm कर लेता हूँ.
When you say thickness of vision, it's a visual acuity. Visual acuity, yes.
Neuropathy. One has to do a dedicated MR of the optic nerve in the eye. When you do an MRI, typically you look for swelling of the disc.
Yeah.
Or you look for something else in the optic chiasm. A dedicated optic nerve MRI would pick up edema of the tract which is within the eye. And it doesn't have the classic symptoms of pain, neuritis, photophobia. It is just a calcineurin-induced thing. And stopping calcineurin usually doesn't help. Our neuro-ophthalmologist recommended high-dose steroid for a month for that. And I was very hesitant to do that, but he has to have vision. And young man, post-transplant, we did it and he had remarkable resolution. But a dedicated optic nerve MR would pick it up.
Good afternoon, everyone. Thank you, Harish sir, for the lucid presentation. So I'll be discussing a case. So our recipient was a 40-year male hailing from Rajasthan, trader by occupation. He was diagnosed case of ILD, query Langerhans cell histiocytosis versus HP since 2021. He was on 5 liters of oxygen for 2 years, height of 162, weight of 60 kg, BMI of 22.9. 2D EQ showed a dilated RA-RV PA, moderate PAH with a good RV function, TAPC of 14 mm. Right heart cath showed a PA pressures of 65/20, mean of 36. ABG showed a type 2 respiratory failure with a PCO2 of 52. Anti-HLA antibodies were negative against both class 1 class 2. Donor was a 15-year male with a height of 162, matching with the recipient. Weight was slightly higher, 75 kgs. Predicted TLC was 5.86, matching with the recipient. Ventilatory settings of the donor were on volume control mode, pressure PEEP of 5, tidal volume of 420, with the ABG showing a PF ratio of 512. CT chest was not done. Bronchoscopy showed minimal secretions in the right lower lobe. There was no repooling with a normal mucosa and patency. Duration of ventilation was only 4 days. Bile cultures for bacterial as well as fungal cultures were negative. TB gene expert was negative. Blood cultures were sterile. CMV IgG was positive. IgM was negative. Counts were 10,000. Procal was slightly high, 4.16. Crossmatch showed crossmatch was negative with the recipient. Cause of brain dead was acute SAH with a status post left frontotemporal decompressive craniectomy. This was the X-ray, donor X-ray. About the transplant, it was a bilateral lung transplant, right followed by right followed by left. Ischemia time was 5 hours and 40 minutes. Induction was done with 20 milligrams of basiliximab and 250 mg solomedrol for each reperfusion. Reperfusion FiO2 was kept at 40%. Second lung reperfusion was finished around at 6 p.m. in the evening. Patient received only 2 FFPs intraoperatively. ECMO was decannulated. Patient was put on central VA ECMO intraoperatively, and patient was decannulated after the reperfusion. OT bronchoscopy showed mild frothy secretions in the bilateral lower lobes. ABG was good. Transesophageal echo in the OT was normal. Patient was shifted to HLT ICU with minimal inotropic supports, inhaled nitric oxide, and ventilatory supports around 9:30. Chest was kept open. On post in the same night, patient was started on meropenem ticoplanin as a protocol. Immunosuppression was as per protocol. Methylprednisolone in tapering doses with myfortic was initiated. After around 6 hours of reperfusion, ABG was done around 11:30, which showed a PF ratio of 176 and CO2 was 72. So chest X-ray was done, which was like this. Bilateral infiltrates, perihilar infiltrates can be seen, haziness. Mean PA pressure was 28 on inhaled nitric oxide of 30 ppm with a PVR of 267 and a pulmonary artery wedge pressure of 11, which was ruling out a cardiogenic pulmonary edema. So a diagnosis of grade 3 PGD was made. So we decided to put the patient on VV ECMO. So antibiotics were escalated to ceftazidime avibactam and aztreonam combination. Blood cultures and BAL cultures were sent. Patient was kept in negative balance. Patient required 1 LDPRBC transfusion in view of drop in HB. Now the ABG was settled. We could reduce the FiO2 to 40% on ventil. Post-op day 2 chest was closed. Inhaled nitric oxide was continued. IO balance was kept in negative. Still patient's FiO2 was around 40-50% on venti. On ECMO he was requiring almost 90% FiO2. This was on day 3 at 72 hours post-transplant. Still patient's X-ray showed significant PGD. So percutaneous tracheostomy was done. Post-op cultures were sterile. However, the PCT was 95. So we continued on Zyvocefta-aztreonam. Post-op day 4, patient developed oliguric acute kidney injury with a rise in creatinine up to 1.58. So patient was started on SLED as per nephrologist advice. Periodic bronchoscopies were done for assessment and tracheobronchial toileting. So these were the X-rays on post-op day 7 with serial SLEDs and with continued ECMO. On post-op day 9, with this X-ray, we could decannulate the patient. ABG improved after this, and this was post-decannulation X-ray. This was post-op day 11. So this was our case.
Yes. So when you've had the bronchoscopy finding intra-op showing frothy secretions, and before coming out of the OR, was there any assessment of how the lung was doing?
So basically ABG was good. So the PF ratio was 380, around 380 in the OT.
Okay. Yes. But this probably is expected then, right?
Yes.
But you had to come out.
We usually get a mild frothy secretions. So
I don't think we usually get mild frothy secretions, which when you suction and it keeps coming back, and that is definitely, it could be a post-trans reperfusion edema,
yes,
possibly.
Yes.
But if it persists after 1-2 hours, that is a PGD unfolding.
So, pertaining to this case, just one question. One of the possible reasons for going into grade 3 PGD is it the age of the donor? Because people usually, most of them focus on the higher age of the donor, and there is some literature that we use very young donors also that becomes one of the reasons for going into PGD, and this was a 15-year-old donor.
15 may not be young. Yes, we've seen that much younger. Yeah, that's one reason. But you have pre-transplant pulmonary hypertension, and your RV-LV may be discordant, and you have an underassessment of LV filling, and you open it up, flood the LV with a lot of
That's
flow.
obviously one of the main reasons for PGD. But is the age contributing here, or it's okay?
See, I mean, that's anybody's guess, but I don't think That's the reason here. You have so many other confounding factors.
Probably not assessed adequately. Like we had
So intra-op TEE usually underestimates this thing.
Yes.
Yeah, CRT is early initiation
Compared to SLED, you mean?
SLED, yeah. It helps us
One would
Yes.
think the X-rays improve because we kept the patient on SLED or negative balance. But even if you don't do it, X-rays will improve.
But the water has to come out. No, how long will it keep?
It will improve. It
How
is
do
the
you-
alveolar fluid clearance.
But problem is LV lung is get wet. No,
There is
LV
one
doesn't
issue,
get fit.
Harish, here. We can't give PEEP in this patient. Chest was open. I mean, PEEP may not be effective. So this is a kind of a, issue
Trade-off.
that we face. We keep chest open. We can't treat the developing PGD.
It may
In
be
which
good, but
case we could have treated if the chest was closed.
See, another thing before closing chest, we think few things like what is ABG, bronchoscopy, and we see the visual recoiling of the lung also. Sometimes we say the lung is porous from the outside also getting wet. In those cases, we don't remove the ECMO. Other times we.
right. But I mean, aggressive negative balance, I remember one surgeon from University of Chicago, and he wrote a textbook on lung transplant. He keeps pushing that Lasix to a creatinine of 3, thinking that that will keep the lung dry and happy. But even if you don't do anything, these lungs will recover. Yes, you need to keep them in a little dry side. No, no, no. I'm referring to being too aggressive on diuresis. And we think that's because of low output or the interleukin cytokines of damaged lung causing ATN. So I can promise you, if you do a UA, you will see tubular CAS on this UA. And if you have oliguria, it is the cytokine mediated damage to the kidney, not the kidneys being underperfused, that is driving. As you're aware, the kidneys work under high pressure. You can still pass a lot of filtering urine even when your flows are low.
And, and also I
So
wanted.
you thought CRRT would probably fix before going on ECMO?
No, CRT post egg.
Ah, okay.
When the urine output continued below, to initiate HCL.
I mean, for being, so looking at it, next time you have a patient with severe pulmonary hypertension going into lung transplant, bronchoscopy showing BA wet lung, repeat bronchoscopy so you can assess it's still draining. Your PaO2 may be great, but preempting ECMO, you would save 5 days of ICU stay.
Would you do a nova lung in this intraoperatively rather than BPA?
To fill, but you did not show me that the LV was underfilled.
Yes, presuming that the LV is underfilled.
If you show me, yes.
Yeah, that's.
I'm sorry.
No, I think you use a nova lung configuration, but use a standard oxygenator. Don't use the nova lung. Just use a standard oxygenator and drive it with a centrifugal pump. Just like an ECMO, left to right. I mean,
Suppose one question here. Suppose the lung is not recovering as we expected. We initially thought it's PGD, but still the infiltrates persisting. Improvement is there. When do you start thinking whether it is an immunological, like ACR setting?
As I said.
Hmm. And when do you biopsy at that time, or you just
Yeah.
pulse at that time? What do you
So
do?
I just discussed that case and showing that there was severe capillaritis, and on ECMO you biopsy, because if your donor, you thought he was young, or you thought the recipient was probably has pulmonary hypertension, that's what is driving. If you are in doubt, it is not classic PGD, you should go biopsy, because early tissue diagnosis will always keep you in a better position.
So we did few of them like that, and it turned out it's like a DID, diffuse alveolar damage. So we didn't know what it is basically.
PGD is DAD.
Yeah. So whether there is a immunological component, I mean AMR anyway, we can have an idea if it's C4D capillaritis. But it was not really. We didn't. The biopathology didn't give an answer at that point. Really, whether it's an ACR or whether it's just PGD related changes, those kind of things. I mean, I guess our pathologists were not really
Okay.
known to this.
Two things. Yes, the pathologists need to be educated and have the literature review. If you had extensive hyaline membranes on the biopsy, you should be thinking about retransplanting. If you didn't have extensive hyaline membranes in the biopsy, just epithelial type 2 pneumocyte damage, you have adequate chance for recovery. And it is not infection driving it, as you thought. The PCT that you look at, it's high, but it's not the infection that's driving it. And so you can exclude other factors quickly. And there is no exudative infiltrates, and you probably just wait and let the lung recover.
Harish, is a bronchoscopic biopsy advisable, or would you do a peripheral wedge?
I mean, most surgeons are very hesitant to biopsy a lung. But
would you pulse it, like test the?
Yeah, we've tried that. It doesn't really help. Increasing the steroids, changing it to dexamethasone, all these funky things we've tried. It doesn't really help. You just weigh it out and it'll recover. And this may be the delayed PGD is usually graft preservation issue. You have to entertain that if you have delayed PGD. Of late, what we are noticing that they have noticed in hearts already, hyperoxia at the time of donor hyperoxia as a risk factor for PGD in the heart that they have published. Often you will see ABGs of 600, and you are so happy that lung is doing so good and you want to transplant that lung. And we saw bad cases of PGD and resistant and ECMO for like 8 weeks to recover those lungs. If we see now, what we are doing is when we see the severe hyperoxia, at the time of clamp, we are reducing the FiO2 for 15 minutes to 50%, and then clamp or aortic before you do the clamp. Hyperoxia. Oh, as you know, free radical.
Sir, I have a question about CMV enteritis or colitis. As you said, ki blood CMV could be normal. Then how could we confirm?
Okay. So in liver transplant literature, it's well published that they don't check CMV PCRs as aggressively, and tissue biopsy will pick it up early. And CMV retinitis, it's probably a board question for all ophthalmologists. They should pick it up by just looking at the fundus.
Okay. Now, about enteritis and colitis, because we see abdominal issues a lot of times. So when, how can we suspect and all? First of all, how do we suspect? We had a case recently. So ultimately, we thought it could be a CMV enteritis. Earlier we thought we ruled out C. diff everything.
So early biopsy. So I know that most gastroenterologists are hesitant to do that, but early tissue biopsy.
So early means like how? What should be
You
the
rule out
threshold?
infectious causes. You stop
Yes.
CellCept, and you see if it's improving. If it's not, then you do biopsy.
Okay. And how do we treat if it is a confirmed colitis? Should we treat it like a
CMV enteritis, like ganciclovir. I had a patient who has some diarrhea, comes in ATN, AKI, serum CMV PCR negative, colonoscopy biopsy negative, the dual lumen enteroscopy biopsy negative, no infection found, comes back with diarrhea, ATN, AKI, creatinines of 5, 6, hydrate, get better. Finally, in a BAL, we identified CMV PCR, treated it, and it got better.
Thank you.
How late are we in the schedule?
1.5 hours.
So Harish, in passing, just before we comment, I'm very grateful to God I did listen to this presentation when I started. So thank you very much. I think it was very elaborate and very.
So we next move on to airway complications post lung transplantation by Vijay.
I think it has been a great morning of discussions. Hopefully, even though we are running late, this is another very, very important complication that will, it's something like, justifies the interventional pulmonologist. Or paisa vasool karta hai ye basically. So if you look at the complications, airway complications. So airway complications begin as early as a week or two, and then they sustain for about a year. So this is a very important in the early phase, especially in our country where donor management is not good, a lot of infections, and post-operative requirement for vasopressors and inotropes are high. There's a higher airway complications than probably outside the country. So this is something that we need to be aware of, and it can really become a barrier in their long-term survival if not treated well. So most of the patients post-transplant surgery will have some sort of an airway sloughing and mucosal ischemic injury. It's around 50 or even more. But the significant airway complications are not that, especially the most dreaded one, the dehiscence are much less, maybe 5% or even lower. The other important complications are exophilic granulation tissues, stenosis. This doesn't occur immediately. It occurs a little bit later, maybe a month later or after discharge kind of thing. And vanishing airway is the other issue which happens a little bit later. And Malaysia, if the mucosal ischemic injury is so severe, even the cartilaginous framework is affected. This is another major issue which can really pull the patient down. Fistulas are not very common, and of course, infections, especially fungal infections, can trigger airway issues as well. So I think Harish went through this very quickly. So there are two bronchial arteries on the left, directly from the aortic arch, and one bronchial artery on the right. They form the plexus. Usually there's a dual circulation with the good oxygenated bronchial as well as a poorly oxygenated pulmonary circulation. We are just anastomosing the pulmonary. So post-transplant, there is always a ischemia which is there. And from the surrounding mediastinum, coronaries, recirculation happens, and it takes about
2-3 weeks. But if your patient is on vasopressors, high dose post-transplant, it takes even longer, especially in the presence of infection. So this is the reason, one of the reason postulated why we have more on the right side airway issues compared to the left side. So I'll just go quickly. It's a very busy site. Risk factors, overall the donors, high mechanical ventilatory support with high PEEP, size mismatches, but more commonly high vasopressor use, hypotensions. So these drive airway complications post-operatively. Ischemic time has been, but there's really no this conflicting reports about this. The prolonged ischemic time may be a risk factor. We don't know. Improper airway, improper donor preservation, poor technique of administering preservation solutions. This is also a very important issue. And from the surgery standpoint, too much dissection, denuding the airway of the bronchial fat or other tissues at the site of anastomosis, using cautery. These are a big no-no. So this should be avoided at any cost, because this is really going to lead to stenosis of that area. Telescoping is also another problem. Prefer end-to-end anastomosis. The suturing technique, if you make it too tight, that is a risk factor. And the donor bronchus length, I'll just go over in the next slide. And right-sided anastomosis, as I said. So the longer the donor bronchus is, the higher risk for airway issues. So we should try to cut it as flush with the, as short, maybe a ring should be the best, and cut in an oblique way. From the recipient side, high PEEP post-surgery decreases the collateral circulation and angiogenesis, high vasopressor use, PGDs or any augmentation of immunosuppression like rejection or infections, all of which will lead to increased airway complications. So we should try to avoid if it's possible, or we should expect that this will happen and try to preemptively look for it and treat it rather than wait for this to manifest itself. And of course, the mTOR inhibitors have been shown to cause delayed wound healing, and so it's customary not to give it in the first 3 months post-transplant because of the high incidence of dehiscence in the earlier studies. Steroids are controversial, but generally we will try to reduce steroids as much as possible. So it does impact survival, especially if there are the main complications, there is definitely impact on survival. So there is a consensus statement by ISHLT for grading as well as the different interventions for this. I encourage you to look at it. It was published in 2018, which most transplant programs follow. So they divided into 4: ischemia, necrosis, dehiscence, stenosis, and Malaysia. Location of where the problem is and the extent. That's how they classify, whether it's perianastomotic, extending, or it's distal alone, or whether it's 50%, 50 to 100%, whether there is ischemia alone or whether there is necrosis. Same dehiscence, whether it's cartilaginous, membranous, and 0 to 25, depending upon the extent of the dehiscence. Stenosis, whether it's anastomotic pus, distal or lobar, or just lobar or subsegmental. And again, the extent. And Malaysia, again, perianastomotic or whether it's diffuse. So these are the various types: ischemia, whether necrosis, infections, dehiscence. I'll show you videos, stenosis and Malaysia. More than 50% of the airway narrowing during inspiration. So if you look at usual immediate post-op videos, this should be done quickly because the more the PEEP is lost, there will be higher incidence of PGD. Look at the mucosa, you just clean up the clots and come out. So it should be a very quick bronchoscopy. Mucosa will be usually a little pink or pale or erythematous, but it will change to a very ash color if there is more ischemic injury. This is common initially, and then it sloughs off because there is not much of mucosal clearance mechanisms. So this is quite common post-transplant. It may be mild, it may be severe, depending upon the extent of the ischemic mucosal injury. But most of them will have some degree of this. So you just need to do periodic bronchoscopies, try to carefully clean it up. You should not be, allow too much suctioning because then it will cause bleeding. These are very, very fragile tissues. You have to stay in the lumen, just suction. And there is a tendency among pulmonologists to put a lot of fluid in non-transplant patients to try to clear it up. This is a strict no-no. There's no lymphatic supply to this lung. So only just touch, suction, and try to clean it up. So this will need to be done. There is no fixed protocol. How long, how many frequently you see it, then you decide next bronch has to be there. So initially you do about a couple of times a week, but if you see more and more ischemic damage, you may have to do every day, maybe even more than that. So how do you manage this? So let's look at dehiscence. So if it's a it's a smaller dehiscence, there may not be if there is a necrosis involving just the mucosa, there's no air leak or anything like that, you can manage conservatively. IV antibiotics, keep it dry as much as possible, frequent bronchoscopies, reduce steroid dose. If you have pneumo, you have to put a chest drain. But if it's more extensive necrosis, then you need to look at stenting. You can do mostly people use uncovered stents just to hold that area, promote granulation tissue and healing, and then you take out the stent basically. But if it's severe dehiscence, of course, you may need surgical correction and re-anastomosis, depending upon how severe and how catastrophic the presentation is. So CT may pick it up, but when in doubt, you have to take a look. So bronchoscopy is quite important and following these dehiscence. When you start seeing the black necrosis, then you have to keep monitoring it in a very close way so that it doesn't slough off and the dehiscence manifests itself after a few days. So you can look at peri-anastomotic air collections or small pneumothorax as well. So these are some the other video which I showed earlier. We put a semi-covered stent just to cover that area. You can go a deeper stent as well if there is good landing zones. Or this is another case for heart lung. You can see the dehiscence. You put a Y stent. So stenosis, essentially you do balloon dilatation, but typically it's not very permanent procedure. It will most of the time it will come back. So we may have to do multiple dilatations or move to another procedures to take care of stenosis, like a stent or hot or cold therapies. Generally, hot therapies cause more scarring, so cryotherapy can be used. But we don't have spray cryo, so we just have the touch cryo. It may not be as effective in clearing, in achieving patency as in a quick fashion. So, but anything which is comfortable for you, you can use to ablate. the stenosis, and then you have to keep following it. Mitomycin C also can be applied, but it's unclear evidence. So you use a combination of multimodality treatment for stenosis, and ultimately, if things are not working out, then you put a stent. So these are some. So these are stenosis. So you. Sorry. So this is an example of multi-modality treatment. So you can use a probe. Probe will come, then a balloon. You can apply cryo and just denature the tissues so that it doesn't regrow again. You can apply mitomycin. So typically you use a multimodality treatment for stenosis. So this was, I think, an NEJM article published maybe 10 years ago. So you look at bronchoplasty balloon, and then if it's resolved, just follow up. If it's not resolved, then you repeat bronchoplastic therapies, or you can try radial incisions, cryotherapy, or finally stent placement. Some problem. Close the problem. Sorry, let me just fix this. Restart. Yeah. So self-expanding metal stents, once you put it in, it's just a temporary measure. You need to make sure you take care of it. Otherwise, there will be a lot of issues, especially granulation formation and blockage and infections. So you need to either exchange the stent, or if it is, if it is not possible or financials are there, you need to take care of these granulations before the stents gets embedded very much, and then you can't do too much about it. So stent is just a temporary thing. You need to take care of the stent or keep replacing the stent till the things settle down. So that's also important. So stent is not an answer; it's just a temporary solution. So Malaysia, that's also another issue. Especially if there is a lot of ischemic injury, the collapse, the framework of the cartilage is not as good. So you treat it conservatively with BiPAP, which gives you a pneumatic stent. Or if there is more problems, more symptoms, dyspnea, mucosal repooling distally, then you put a covered stent or a silicone stent. So I'm going to skip this. Of time. So the other thing is exophilic granulation tissue. So this can cause obstruction. It can be a nidus of infections. So this can be either dealt with hot or cold therapies or debrided. Otherwise, this can be a problem as well. So airway infections are common. So this was a recent case whom we had. Once you see these patches, then you need to take a swab from there, or start antifungal treatment. It's quite common in our country, especially in the metros where Aspergillus infection is quite high. So you need to keep looking for it. So this was our study we published earlier in chest. So we had airway complications about 29%, anastomotic stenosis 20%, Malaysia, dehiscence that time about 5% of that. This was our earlier experience, about 100 transplants. But still airway complications roughly about 30% we do get. So this is our survival data. So that's it. I'll just go to the case, then we'll have a discussion basically. So this is a 24-year gentleman, negative cross match, underwent combined lung heart lung transplant for idiopathic PAH with severe right ventricular dysfunction. So his post-op course was uncomplicated, no PGD, no major sloughing issues. And when he was getting ready to discharge, maybe a few days before, his ball grew pseudomonas. So he was discharged. He was doing fine, walking around. So he was discharged about day 19 on IV antibiotics. So, and then subsequently, a couple of bronchs were done, all of which was continued to grow pseudomonal infection. So this was one of those surveillance bronchs. So you can see the anastomosis was starting to way I can control this setting. Yeah, I want to just fast forward a little bit. Where is this? It's not showing up actually. Sorry, but you can see this developing ischemic area here, right at the anastomosis. And then yeah, so then it started breaking down. You can see this pouch developing. So definitely dehiscence happening. So CT scan done at that time also showed that with some pneumothorax small. So you can see that small rent here, and then there was a small pneumothorax as well, which I showed you the picture earlier. So these are subtle signs if you look at just the CT, but obviously the bronchoscopy was showing a much different picture. Patient clinically was doing fine. He didn't have any symptoms at all. So we did put a Y stent, also antibiotic, mucolytic therapy, multiple cleanup bronchoscopies. Subsequently had biopsies, which was negative for rejection. So this was a covered Y. So over the next few weeks, we followed up with CT scans. After 8 weeks, the stent was removed and anastomotic sites had healed, and he's doing pretty well. So this was a video just after removal of the stent. A lot of granulation tissues. This was taken care with cautery and ablation and all. So this was the anastomosis. This is actually the other way. So it's quite well healed, and this is a subsequent video after a month or so, which shows well healed anastomosis. show you the dehiscence in a second. Yeah. So bronchoscopic metallic stents is a viable option for tracheal dehiscence post combined heart-lung transplant. Thank you. So just a comment here that post-transplant inotropes, vasopressors, these are very important. We try to reduce vasopressors as much as possible. Otherwise, most of them will get airway complications, especially if they have high risk factors like donor issues or PGDs or rejection, which but this is very common in our country, with other programs also having similar issues. You need to have good interventional pulmonary backup, especially for doing these procedures. Any other questions?
But bronchial stenosis in the postoperative period, usually it is said that silicone stents is the treatment of choice. But now there are so many reports which are coming that covered metallic stents are also used, because in benign stenosis, metallic stents is a big no in other cases. But in post-lung transplant, now people are saying it can be done. So what is your take about that?
Yeah, for stenosis, usually the problem with silicone stent is because the airway is not really a tubular structure. Distally, I'm talking. If it's tracheal silicone stents or major airway, we can still go ahead and use. But silicone stent, the airway is quite twisted at that point, and silicone stent may not stay as good. It is not always going to be a snug fit. There will be some secretions, so infection rates are high. So we generally don't prefer a silicone stent. We do a covered metallic stent which nicely, snugly fit that better than silicone stent. And also there may be, if there's no landing zone for the stent, that is if there's anastomosis and the upper airway, upper lobe takeoff is immediately after, or there are like 2-3 openings immediately distal to the anastomosis. So the silicone stent doesn't have the the landing zone for that. So because there's one airway right there, either you cut open the silicone stent, make a hole for air to go. In those cases, you may even have to put an uncovered stent so that the upper lobe airway is patent. You may have to put a stent from the RBI up. You can, so the upper lobe is aerated through the stent. So silicone is good, but there are a lot of practical issues with that.
For TBM, silicone may be a better option than metal stents, but for stenosis, I think everyone is clear that transplant airway is not a benign airway disease.
Yeah.
When we are referring to benign airway disease, it's really relapsing polychondritis, Wegener's. Those are the diseases that we are referring to, that where we prefer not to put metal stents, not a transplant airway. And no literature in transplant has shown that using metal stents for any of these complications has any adverse outcome.
So now we move on to post-transplant infective complications. It will be dealt by Dr. Unmilch.
Yeah. Good afternoon, everyone, and I will just keep my talk short, just highlighting the basics about why the infection risks are so, the probability and the possibility and the incidences of infections are so common in lung transplant, followed by 4 interesting cases, and then we will have a longer time for Q&A.
So coming to basics, as we all know that lung transplant has been the definitive option for saving lives. For saving lives of patients those who suffer from end-stage lung diseases. But we also know that the immunodeficiency following the exposure to immunosuppressive drugs prescribed to reduce the probability of rejection increases the risk of acquiring life-threatening infections. And also the host-related biological agents and the environmental factors do affect the infection risk, specifically in the Indian settings. So what are the host predisposing and the lung transplant predisposing factors? So patients with CF and in our part of the country with non-CF bronchiectasis, diabetes mellitus, obesity, malnutrition, LTBI, colonizations with multi-drug bacteria, chronic renal failure, and the need for mechanical ventilation are all the risk factors for a post-transplant bacterial infections. And the recipients, those are usually in lung transplant setting, are affected by a complete disruption or a partial loss of physical barriers. And that predisposes to risks for following medical conditions like whether it is aspiration pneumonitis because there is no mucociliary clearance, central and related infections, urethral infections, C. diff, and sepsis. Coming to bacterial infections first, during the early post-lung transplant period, maybe few days to 1 month later, the nosocomial microorganisms account for majority of the infections. And patients with CF and non-CF bronchiectasis usually have more of colonizations, and therefore the recipient or a donor harbored infection, usually by Pseudomonas, NTM, or Burkholderia, are common in patients with CF and non-CF. Coming to risk factors for bacterial infections. So what are the risk factors? So you have first is a transient disruption of the bronchial circulation, which may cause the loss of epithelial integrity and as well as ciliary function and mucus production, increasing the risk for infection. The second risk is the denervation of the allograft, which may suppress the cough reflex, promoting more of colonization and bronchial inflammation. Third, impaired lymphatic drainage of the allograft, which can result in stasis and edema of the bronchial tissues, slowing the normal healing and promoting superinfection. And in fourth, in case if there is necrosis of the bronchial anastomosis, there is colonization of bacteria there, which can increase due to reduced clearance of secretions. Also, the immunosuppression as well as the type of immunosuppressant agents what we use to prevent to prevent rejection, which can lead to prolonged T and B cell dysfunction and or macrophage and cytokine dysregulation, which exposes recipients to the risk of bacterial pathogens. So coming to timeline, we have risk of bacterial infections. In the initial weeks, it is more of Staph aureus, Enterococcus, Enterobacterial, Pseudomonas, Acinetobacter. And as we go on, in the later part, as a long-term follow-up, specifically in the Indian settings point of view, you would encounter either a TB or an NTM. So risk factors we have gone through. Prevention, there is very less prevention modalities what we can use it for bacterial. Vaccination status, we have only one vaccine available, which is pneumococcal, and they say that almost 6% of the recipients are predisposed to get a pneumococcal pneumonia. So probably vaccinate them well preoperatively. Look for the LTBI, active TB, travel history, colonization by MDR bacteria, which is one of the most important risk factors as far as the Indian settings are concerned, which can predispose to recurrent bacterial infections. Coming to viral infections, CMV is the most discussed virus and most frequently detected viral agent during the first month and from 2nd to 6th. It could promote other infections, and it's a known fact such as EBV related PTLDs and acute and chronic rejections. And CARVs, which is the community acquired respiratory viruses, are quite common within 1 year of post-transplant. Coming to CMV, the highest risk of CMV as defined by the American Society of Transplantation as evidence of CMV replication regardless of symptoms and disease where there is evidence of infection with attributable symptoms can be explained by the huge lymphatic reservoir what the lung has and the high level of immunosuppression which the lung transplant requires. Obviously, as we all know, D plus R minus is one of the highest risk for getting CMV. But in India, we have more of D plus R plus, where there is still a moderate risk for getting this CMV infection. So as per the AST guidelines, they recommend 12 months of prophylaxis for D plus R minus and 6 to 12 months for D plus R plus or D minus R plus. Our protocol has been to continue, long-term CMV prophylaxis. That is what the protocol what we follow. Coming to EBV, which causes the latent infection, and as we know, as we do the workups, we see usually EBV IgG is positive, CMV IgG is positive for most of our recipients. So there is a latent infection in almost 95% of adults in this part of the country, which sometimes can predispose to severe and disseminated infection and to PTLD, where the transmission occurs from D plus to R minus. But I will be showing an interesting case where we had a transmission, from D plus to R plus. So almost 10% of the LTs or lung transplant recipients can have these EBV-related PTLDs. High level of immunosuppression may contribute by promoting EBV-infected B cell escape from T cell-mediated immune surveillance. Several studies have also highlighted that some association with some induction agents, high viremias, and with the risk of PTLD. Coming to COVID and lung transplant, I'm not going to much details about COVID as we all have handled in the last 2-3 years. But this was a paper published which highlighted about does the SARS-CoV-2 increase the risk for lung allograft dysfunction from US, and it showed that 35% developed LAD, which is a new terminology, which is an acute lung allograft dysfunction, which can in the long term go into CLAD. 35% recovered of FEV1 after LAD and 10% died. Coming to viral infections timeline, we have 6 months. Initial 6 months, you can have CMV, EBV, rest of the viruses. CRVs and all community acquired can come any time within 1 year of post-transplant. And what are the preventions for those viral infections? Check the vaccination status. Do pre-vaccinate them pre-transplant. Annual vaccines against influenza post-transplant again is a recommended thing. Look for silent viral infections. Do the UR upper respiratory tract biofire swabs to look for RSVs and adenoviruses and metapneumoviruses and etc. Travel history again very important. Also, a systematic monitoring of CMV and EBV post lung transplant is highly recommended because sometimes these viremias can be silent to begin with. Coming to fungal infections, according to Transnet, 8.6% of the recipients develop invasive fungal infections during first year after lung transplant. Although the incidence may vary, fungal pneumonia contributes to around 35% of the pneumonia-related deaths during first year after transplant. Aspergillus definitely is the commonest, 44%, followed by Candida. What are the risk factors for fungal? Again, anatomic and physiological impairments, what we have seen. Environmental exposure, I think from Indian settings is very important. So farming, construction, air conditioning, filters increases the risk for invasive fungal infections. Airway ischemia, neutropenia, more importantly, hypogammaglobulinemia, T cell depletion, and an over-immunosuppressed state. The need for bronchial stents, co-infections with CMV can also predispose to invasive fungal infections. Colonizations, just benign looking colonizations with Aspergillus tunnabal, nothing on parenchyma, still becomes a risk factor for invasive fungal. Prophylaxis, minimization of environmental exposures, use of personal protective equipments. We commonly use nebulizations, embisomes or liposomal amphoby. Triazoles are commonly used as antifungals, as we all know, and voriconazole is the most frequently administered antifungal. Isobuconazole now lately has been started using it in enough literature for prophylaxis and treatment in invasive fungal infections. So coming to timelines again, first 1 year you have Aspergillus, Candida, and after that PCP or PJP, which I will be touching in my next slide. Just a small comment on the parasitic infections about strongyloides and T. cruzi, which we need to keep a low threshold while evaluating in specific scenarios. Coming to PJP, lung transplant is burdened with high risk of PJP among solid organ transplants, and prophylaxis is recommended for a minimum of 6 to 12 months in case of standard risk and lifelong. Our protocol is to give it for lifelong. We know that Bactrim or Septran is the commonest drug of choice for prophylaxis, but in case you have sulfa allergy, Dapsone, aerosolized pentamidine, and atobacon are the possible agents to be used. Coming to granulomatous, TB or NTM, again, very common in this part of the country, and mycobacterial infections must be considered among the differential diagnosis. And there are sometimes problems, challenging situations where there are delays in diagnosis due to the fastidious culture requirements and the complexity of the treatment regimens with the drug interactions. So always look for the mycobacterium. And what are the pathophysiology for getting these mycobacteria? Either it could be immunosuppression induced reactivation of latent TB in the recipient. Second pathway is either there is an acquired infection by transmission of MTB from a contagious person, or you can get it from donor. So case 1, interesting last 4 cases, which I will sum it up, and then we can have a prolonged Q&A. So this was a case 1, 66-year-old female, bilateral lung transplant. This was a patient done by a different lung transplant team, and since the patient stays in Mumbai, had come for the follow-up, presented with fever, cough, and leg pain. The X-ray showed, I will be showing the imaging in the next slide, showed on the left upper lobe consolidation. BAL turned out to be no cardiosis, no CNS involvement on CT brain. Started with the injectable IV antibiotics for 14 days, nebulization, tobramycin, followed by tablet minocycline for a prolonged period of time. Had a right leg DVT at the simultaneously and started on anticoags. But as a part of DVT workup, turned out to be cardiolipin antibodies positive. And she had also had a deranged creatinine for a long period of time. So evaluated for BK virus and definitely had a significant viruria, so suspected BK virus nephropathy as well. So she had three things together: nocardia, APLA, and BK viruria. So this was the X-ray, left upper lobe consolidation, the CT scan, and after a prolonged therapy with the sensitivity as per of the nocardiosis, it showed a complete resolution of the nocardia pneumonia. Coming to case 2, 66 male, bilateral lung transplant, fever, cough, DOE, radiologically bilateral pleural effusions with only right lower lobe consolidation. BAL was not conclusive, did a PET, turned out to be a large necrotic mass in the subcarinal right infrahilar region with GGOs with considerable changes in the right lower lobe. We went ahead with a CT-guided biopsy which showed a monomorphic B-cell driven PTLD high grade EBV related non-Hodgkin's lymphoma of diffuse large B-cell type non-GC subtype. The EBV viral load was very high, started with the 4 cycles of Ritux, did an interval PET scan. Depending upon the good response, we did go ahead with 4 more cycles of Ritux, and then it showed a PET complete remission. So this is the PET at the start of the therapy where there is a lot of active areas, and this is after 8 cycles of PET where it shows a complete resolution with a normal, with no viremia. Coming to third case, 47-year-old female, status post combined heart lung transplant, known case of scleroderma underlying, had taken 4 doses of mRNA vaccine in UK, presented with fever, DOA, cough, mild desaturations, upper respiratory tract biofire swab showed SARS-CoV-2 positive, bilateral lung involvement on the HRCT, inflammatory markers were normal, immunosuppression modulations, remdesivir and anticoagulation prophylaxis helped sail through. So this is the video of the CT scan showing the typical GGOs, what we have seen in SARS-CoV pandemic. Small pneumothorax on the right side. And as we go down, you will be able to appreciate the COVID lung typical presentation. So she has done very well, surprisingly, and she has recovered from this COVID. So this is again the COVID and lung together. Coming to last, case 4. Now, this was a 60-year-old male, isolated thrombocytopenia. I mean, I used to ask him multiple times, do you have any clinical symptoms? He used to always deny, no fever, no cough, no DOE, just isolated thrombocytopenia. HRCT showed a right lower lobe consolidation. BAL was inconclusive. We went ahead with the CT-guided biopsy, which turned out to be granulomatous lesion, turned out to be tuberculosis on culture, post-TB treatment, platelet count normalized, and radiological resolution. So this was the CT scan right lower lobe consolidation, and the CT guided biopsy turned out to be MTB, and this is the treatment completing after 1 year of the post-TB treatment. So this was the report where it showed an epithelial granuloma and giant cells, prominent areas of necrosis. Surprisingly, and obviously it correlates, there were arteries which showed intimal proliferation and thrombosed lumen, and this was the MTB complex isolated at 6 weeks of the culture. So take home message as far as infections are concerned in lung transplant, the commonest differentials in lung transplant, keep a low threshold for interventions, BAL or biopsies, tissue biopsies, look for atypical presentations as how it was there in the case 4 or the last case of tuberculosis in the lower lobes. Tailoring immunosuppression is always the key, and prevention is better than cure. So do vaccinate whatever vaccinations we have available, and that definitely goes a long way. Thank you.
So before we break for lunch, we just have a 5-10 minute session by Dr. Samuel on career prospects in lung transplantation in India.
Good afternoon, all. Coming to the last topic of the session, career prospects as a lung transplant pulmonologist. My talk is primarily aimed at the pulmonologists in the room. I know we should be having food by now, but I'm just providing you with some food for thought. So, conflicts of interest, there are none. All these, there's a bit of repetition because my colleagues, Dr. Moyes and Ois, have briefly touched upon all this. history of lung transplant. The first lung transplant was done in 1963, and there were over 40 attempted, where after which we actually had a successful lung transplant in the year 1983, and the first double lung transplant was done in the year 1988. And since the early 2000s, double lung transplant has become more common. When we look at the Indian scenario, the first combined heart lung transplant was done in the year 1999, and the first single lung transplant was done for an Iraqi patient in the year 2011. And in 2012, the first lung transplant for an Indian national was done. This is NOTOS data. As we see in this graph, you see there's a gradual uptrend in the number of donors, that the number of donations that are happening in this country. Understandably, there's a dip around COVID. So you can also see that there's a gradual uptrend in the total transplants. And this is specifically about the lung transplants. 10 years ago, it was in just double digits. So you can see slowly the numbers increasing. Of these, if you look at it, these lung transplants of 144, almost 80% are done by this institute. So coming to the developments in the lung transplant, in the field of lung transplantation, it is becoming increasingly as an accepted treatment option for end-stage lung diseases. There's an increase in survival, increase in improvement in the quality of life achieved, and with more bridging techniques available, there is ever increase in the waiting lists. So as a career, with all this backdrop of all this that I've told, as a career, it is emerging as a field with increase in the number of centers and increase in the burden of lung diseases in India, and the increase in the waiting lists and increase in donations. There's an obvious increase in the demand of a transplant pulmonologist. So when we come to the transplant, how the transplant is in developing countries, we face a unique set of challenges because of late referrals, because of lack of awareness of transplant as a treatment option, and nutritionally, the low nutritional reserves especially, and also with the lack of bridge therapies and all. And donor related, obviously, there are very few donors, and very few centers have donor optimization techniques such as EVLP. And post-transplant management, not everyone is aware of proper post-transplant management. So these are if we look at the lung transplant centers in India, most of them are concentrated in south of India. So what it basically takes to be a transplant pulmonologist. So if we look at the clinical experience, you should be able to properly evaluate a pre-transplant patient and take care of a post-transplant patient. Bronchoscopically, you should be able to perform serial surveillance biopsies, and as Sir said, good at airway interventions, and also we have to do proper periodic surveillance biopsies. And critical care, you should be good at taking care of the patient post-transplant in the ICU, and also you should be able to manage ECMOs, especially in cases of PGD. On the floor, while we do the floor rounds, we look at immunosuppression. We have to adjust the immunosuppression levels. We have to suspect and manage acute rejection, if any. And in the OP, we have to properly evaluate a patient who is referred to us for a lung transplant and optimize him prior to the transplant, and obviously the post-transplant management. And donor call, as Dr. Vesa said, proper assessment and optimization. So all in the pulmonologist, transplant pulmonologist, how his day is. So we evaluate a patient, we discuss with the whole team and list the patient, and while he's on the wait list, we have to keep them alive, we have to optimize the treatment, we have to rehabilitate him. If unfortunately he develops a respiratory failure, we have to bridge him on an ECMO for the transplant, and post-operative care and long-term follow-up thereafter. Transplant is not everyone's cup of tea, which when I joined this institute to work in the transplant team, I did not understand anything of it. So I was thinking to run away. But then on one particular day, I would say it was more of a life-changing event. When I was on my night duty, and this patient who was on ECMO for close to a month was had a prospective call, and the organs were good, and he was about to be wheeled into the OR. That's when I saw his family. He had a 8-year-old kid, and that moment changed my life. The if I could give, as a father of a parent, if I could give a kid back his father hale and healthy, I think that's a huge achievement in itself, and it's a great purpose in life actually. So, but nonetheless, it's not everyone's cup of tea. You should have the aptitude for it. And also, the slide is a reminder, when you're in Hyderabad, don't forget to have Irani chai. So whatever it takes, so what it truly takes. So to be a transplant pulmonologist, you have to be a team player and a problem solver. You have to be very diligent. You should be definitely be willing to work beyond your work hours, and you should be inclusive to everyone's ideas, and you have to have utmost empathy, and you have to be very good with your communication skills. I know in medicine, every field should have all these qualities, but in a transplant unit or as a transplant pulmonologist, we should have all these qualities at a different level. So if you're a transplant pulmonologist, the advantage is you're an expert physician. You have diverse pathways. You can get into research. You have the chance of interventions, critical care, everything. It's like a dissection of multiple medical, disciplines. And you obviously have a high impact on the patient and the family's life. So where do I pursue a fellowship? That's the next question. So you could just Google it. Abroad, there are many centers that offer you transplant pulmonology fellowships. And in India, we at the KIMS is at the cusp of starting a fellowship in transplant pulmonology. It should happen very soon. I'd like to close my, talk with a quote which is very close to my heart, which is what has happened to me, which was said by Robert Frost. Two roads diverged into the woods. I took the road less traveled, and it has made all the difference. Thank you from the bottom of our lungs. Take.
I think we should have put it a lecture before. You would have enjoyed Unmil sir's talk well. Fine. So on that note, we break for lunch, and post lunch, we'll come back to this hall for an EVLP demonstration by our surgeon, and then on we break into 10 groups for the workshops. Yeah.
So can you come up with your the diagram of your circuit? No, you don't have the circuit diagram. Okay. So basically, the concept of EVLP is basically to nourish the lung and kind of keep it ventilated during that time. This is a great thing for basically borderline lungs that can kind of be put on EVLP and then reevaluated, and that kind of increases the acceptance of lungs from about 20% to somewhere around 30-35%. This is a pig lung that we have obviously harvested this morning for this purpose of the demonstration. There are some inaccuracies, as in the pig is basically killed with a little bit of injury to the trachea. That's how slaughterhouses kind of kill the pig. So there will be some amount of air leak which you can see that is present in this line, but we're trying to get on top of it. Some of you I think, have been here to see how the LA cuff was constructed around. It's basically a funnel-like cuff that is constructed around the LA and sutured either with a Prolene or whatever suture of convenience. The pulmonary artery cannulae can be directly, with gentle manipulation, put in the pulmonary artery and can be secured with tie. Same for the endotracheal tube, standard endotracheal intubation, and it can be secured with ties. the advantage of a compact EVLP is that while the lung is kind of in the EVLP and the lung is kind of getting the nutrition and the ventilatory support, you can also sample the ABGs, as well as you can also do bronchoscopy to see how the lung has improved. Sir, Vijil sir, so what do you want to say? Sir, we can talk later part of. सर को मेरा वाला माइक सर को ही दे दीजिए आप मोहित सर गिव अ माइक सर
So this is just a demo of the EVLP circuit. The circuit has obviously the dome. Then we have an ECMO machine or a pump. There is a filter. There is a reservoir for filling for the solution. So the solution used in EVLP is the Steen solution. The idea of EVLP is to maintain the lung, to kind of dehydrate the lung, get the congested lung, the fluid in the interstitium out, and also we can condition the lung. It gives us time to assess the lung. Many a times we don't have time to assess the lung pre-op, or there may be a marginal donor lung. We need more time to assess, inflate, and then improve the lung condition so that we can use it for transplant. So this was started essentially by Stig Steen initially on a DCD donor. Then the Toronto group really took it forward. So initially it was the perfusate was a cellular perfusate, that is blood-based. But the Toronto group made it a acellular perfusate, but still used the Steen solution. So Steen solution is a solution made of mainly albumin. There's some dextran into it and glucose and other elements which will provide nutrition to the lung. It will dehydrate the lung, maintain it, and then we have to keep periodically replenish the solution. So once the donor comes in, there is this EVLP room. Either it may be inside or there may be a separate facility for it. So it resets the cold ischemia time. So once the EVLP is done, again the ischemia time drops down to 0. So you have another 7-8 hours, for the cold ischemia time too. So it can prolong the ischemia time and make a lung transplant like a day procedure, or logistically you can use it. So that is another advantage. So mostly used for brain dead donors, for bad donors, marginal donors. For circulatory DCD donors, it is most of the time it is required, because anyway there is a bad ischemia which happens when the circulation is cut off. So these are the main indications along with the logistic indications. So there's an ECMO circuit, there is a reservoir, the pump. There is also a leukocyte filter in the circuit, but you can, because of the unavailability of filters, either you can do a cytokine filter which does the job. It can do a cytokine removal while on EVLP. So the other thing is a lot of therapies we can do, like gene therapy. They can do interleukin-10 therapy to improve the condition. Antibiotics can be given. Cytokine removal can be done. People are using even nutrition, TPN, for prolonged EVLP. So a lot of things can be done while on EVLP to condition the lung. Mesenchymal stem cells can be used, but these are all still in the domain of experimental treatment. But definitely the regular EVLP to extend the ischemia time, that is proven. And also it improves the retrieval of lung from the traditional 20-30% to almost another 30% marginal lungs can be harvested by using the EVLP. So there is anything else surgically? Manu, you want to add something? How to? So as Vishnu mentioned, the LA cuff is a special cuff which is sewed over, then the PA is done and then connected to the ECMO run.
The air we use, it's a deoxygenation which happens because we remove, it's not actually oxygenation. The special air mixture is mostly only about 7%, 8% oxygen, the rest is nitrogen and carbon dioxide. So we de-air the lung, and there are different protocols to run it. The most commonly used is Toronto protocol, where they use they gradually warm the lung, then they start ventilation at 6 mils per kg. Then every hour they assess, change the tidal volume to 10 mils, recruit the lung, and then they measure the PF ratios, they measure the lung weight, they measure PVR, they measure PA pressure, LA pressure. So after the usual run of EVLP is about 3-4 hours. Usually more than 4 hours, hardly anybody uses it. By the time you have an idea how much is the steam loss, how much is the edema happening, or how much weight is being gained. So there's a gradual improvement in PF ratio. But if the and the weight is well maintained, the PVR is good, PA pressures are good, LA pressures are well maintained, then you can use the lung for transplant. Any other questions from anyone? You can. So general EVLP run is about 4 hours, so, but there are extended EVLP runs. It can be up to 10, 12 hours as well.
Do we need to change the solution and the
Yes. So initially the priming volume is around 2 liters. Then either you can do every hour, you can change to 50 ml, or after end of 2 hours, you add another 500 ml, and then every hour or so you can keep adding. It depends on the blood gases, a lot of things. How do you run? But you have to exchange in between.
blood gases we have to take directly, or
Yes.
we have to?
You take directly from the reservoir. Yeah. So temperature of the perfusate is a normothermic temperature. So initially it can, yeah, initially at 28, and then you gradually rewarm the solution. Yeah. And after you reach 32 degrees, then you start the ventilation. Basically. Similarly, at the end of EVLP procedure, you cool it down and then put the lung in the refrigerator or ice box. And then you have reset the ischemic time starts from there, basically, again. So Perfodex, at that time, at the start of the EVLP, you flush again with Perfodex. And at the end of it also, you do Perfodex.
So is there anything different during harvest when we know we're going to put the lung on EVLP?
So as I said, the indications are it's a marginal donor. You don't want to put a good lung through all these things. It's quite an expensive procedure, to be honest. But if it's a marginal.
Steps. In the surgical steps, is there anything different?
Yeah, surgical steps.
Yeah. So after harvesting, then we'll have to cool the organ for about 2 hours. We'll keep in ice box or regular whatever 10-degree organ box, and then after 2 hours, then we take the organ out, and then we get ready with the circuit. The perfusionists they will ready the circuit, and then we take we anastomose LA cuff. It takes some time. Other than that, then PA and endotracheal tube is just regular silk ties, so it doesn't take much time. So once everyone is ready, then we start. Perfect.
So we start with the perfusate first or with the ventilation first?
No, first perfusion. Okay,
first.
yeah.
Followed by
Slowly, and it's like it depends. Okay, there are like 3 protocols: Toronto, then Hanover. So 32. Ventilation is at 32.
And specific ventilator settings?
Ventilator setting, it depends. So regular ventilators are respirator.
And then weight is around 10. Peep.
If FiO2 is assessment.
Every hour you go, you increase the tidal volume. That's the assessment set. So assessment is done at 100%. Just to take 5 per kg at 100%. That is the assessment setting. And then you go back to the resting setting. Yes, there is a weighing scale where it's kept.
We have not
Actually,
turned
this is
it
the
on.
weight. It's not connected now. So it will continuously read the weight.
Whether this much is the.
So you look at the trend. If the lung is getting more water-logged, edema, weight is increasing, then that's not a good sign. Should maintain the weight throughout, or there should not be too much of a weight gain.
Or it should come down.
Yeah.
Yeah, if it's come down, as even better, basically. Yeah.
Is there any specific markers or pointers that it should be coming down by 10% or 5%?
It's just the trend. Just the trend.
Just the trend.
The hemodynamic parameters which should be improving, ventilatory parameters which should be improving. Okay. So we just see the trend. So, and it's like we use Toronto protocol, so we use 40% of cardiac output based on the donor's weight. Okay. So in Hanover, they use 100% of cardiac output. We use Toronto, so we use 40% of cardiac output. So based on that, we slowly come. Once we start perfusion, slowly we increase the volume of perfusion slowly, so that by the end of 1 year, we'll reach 40% of cardiac output. We stay there, and system stabilizes at about 2 hours time. We can assess at that time, and then if everything is okay, we can actually decide whether we can take the organ or not at 2 hours. Up to 4 hours is okay. They have done up to 6 hours, and even up to 12 hours they have run EVLP. Yeah, it should be more than there are like, it depends, delta P of more than 350, some says more than 300, and then ventilatory parameters it should be improving, and also hemodynamic. There are a set of parameters, so it should be an improving trend. It should not deteriorate, and weight obviously it should come down. The 100% the FiO2 will save for the ABG. No. It's like we start ventilation at 0.21, and then during assessment mode, we make it a FiO2 of 100%. So assessment mode is 100%. So we check all the parameters at 100% of FiO2.
That is for 5 minutes only.
Yeah. After 5 minutes.
Every hour?
Yeah.
5 minutes.
Yeah. With the same perfusate, yeah. Yeah. We have inline this one also, TH system.
Heparin 2500, no?
Yeah, heparin 2500. No, we can
So
add.
generally,
Usually
we
we
give
add
antibiotics, meropenem,
meropenem, and methylprednisolone can also be added.
and heparin. That's it. That is just in the circuit. You add in the beginning. So you can put a leukocyte filter. You can remove the cytokines. And other advantages, you can do X-rays. You can perform bronchoscopies. You can remove clots while the thing is running. Yes. Yeah. Yes.
Excuse me, sir. Sir, any specific reasoning for the lower oxygen concentration in the ventilation part? Like you said that the FiO2 will be very low. You'll use an air mixture along with nitrous. So any
So
specific
higher
reason?
oxygen is toxic.
So regarding
And
the
you
routine
can't
free
assess,
radical
no, if you're
production.
giving oxygen, how are you going to assess the lung function?
Okay.
There is
And-
no.
okay. Because invariably the ABGs will see the relative oxygenation of the blood.
Yes.
So just to avoid the oxygen toxicity, do you go down on oxygen?
So in most of the study, there is really no advantage of one protocol to other. So you can use any protocol you're comfortable with.
So we have now got the donor lungs, and now we have in-house patient. So what should be the timing of wheeling in the patient in accordance with the assessment parameters?
So most of the time, when the donor organ comes, if it's a marginal donor, if the decision is to use XYO, you need at least 3 to 4 hours on ex-vivo, then cool the organ. So easily be about 6 hours, 7 hours, and then you can do the recipient weaning. But most of the time it is done for logistics. The organ comes at 2 a.m. You do ex-vivo. Morning the surgeon will come and start the surgery.
So this will continue till the time of dissection of the hilum is done. No.
You run it, then pack the lung, put it in ice box, then the surgeon comes and uses it.
Yeah,
Again, you
it's
have
zero
to cool.
ischemic time.
So basically, once you know that your lungs doing well,
Yeah.
you platform to pull it, you arrest it, and you
Store it.
simultaneously your recipient comes in.
Yes.
And your clock has reset once again. So you have enough time.
That is if the indication is logistic and you want to
Any-
restart.
anyway.
Okay. So basically, we have restarted the ischemia time.
Yes.
Reset the clock.
The other question, Niranjan, you had about different protocols. One is an OCS protocol, that is a transplant. You know that. So it's a controlled distribution with blood. That is from the donor or the positive. I mean, or the O negative. If you look at the other protocol, one is obviously the acellular Toronto protocol.
It's good to see
Where you actually add blood. The idea to add blood is to basically get you some better delta P's, and I believe that they also say that the blood carries oxygen better. So, but Toronto and all the results, health trials, novel, all of them have demonstrated that acellular oxygen is fine. So, yeah, cost-wise, yes, probably it is better than the OCS. It is cheaper. Logistic-wise, yes, it's a stationary machine, so you have to bring the organ to the center. You have to have an EVLP at your center, or you can probably treat the lung elsewhere and bring it along. That's the other thing. With the transplants, you can probably move it along. I think it's far more expensive. I think it's prohibitively. Yeah.
So OCS is a bit, only this manual EVL. This is not portable.
But the good part about a manual EVLP is you can any lung transplant center can do it. But what you basically need is you need all these disposables, consumables, and you need steam. So an average run, like Vijay said, if you use 3 liters of steam on a donor, it will cost you anywhere between 18 to 22 lakhs just for EVLP. So that is the kind of shift that you have to make in your thought as to whether your patient will really afford it. And the other risk is that suppose it doesn't work, then who absorbs the loss or the cost? So that is the major challenge. So probably that is one of the reasons why it doesn't work. But I would like to bring Harish in here towards the end of the discussion. He'll probably tell you about the lung guard, which in his belief is something that will probably upend EVLP eventually. But having said that, I think this technology probably has some promise, and like it can probably allow you to deliver mesenchymal stem cells. It can modify the graft. You can probably change the blood group, and you can probably do non-compatible. You can treat HCV probably. I don't know. They're doing it with hearts. Probably you could use light therapy, phototherapy. So there are many. It's a great platform. I think I don't know if you've done it with lungs, at least in pigs. You've changed blood group, you've created a universal donor. I don't know whether it's a foot ahead for organ transplantation overall. Whether we could do the same for other organs.
Finish you to use it.
We just use Perfidex and we just arrest. Yeah, we just arrest the lung. Yeah. So I think even on the run, you've already done all you need to do. You've perfused the organ well. You've treated atelectasis. You've probably reduced lung edema, extracellular water. You've probably treated with antibiotics, antifungals for infection. So you've probably done almost all of it. You've done bronchoscopies. You've cleared the airway. You've sampled. Going forward, you can also actually do biomarker testing. If there's a lovely paper which allows you to treat the damaged lung. So they use an adenovirus vector, and they transfect the adenovirus vector, which is non-replicating by nature, and it increases the IL-10 expression in the donor lung manifold. So that probably is protective for PGD. We've done it with lentivirus. There are many vector-based therapies that you can implement going forward. But these are all kind of I think still in the laboratory. Not really sure how much will come into clinical practice. I'm confident somebody will bring it to you, but it's a great tool.
Any correlation between PGD and timing of duration of this, and whether we are using this or not?
So when they did the novel trial also and the health trial, the incidence of PGD doesn't
the
come down.
same.
It's the same.
Same.
So there's no advantage as far as EVLP is concerned with PGD. I think the fundamental understanding is it allows you to expand the donor pool. So technically, if you expand the donor pool, which currently is 20% of all utilizable lungs, if you can expand it to 40%, which has been demonstrated, I think that is the real opportunity. So you expand the donor pool and you transplant more patients, having confidence that your marginal lungs will work equally well. So that should be probably a take-home message from my side. Harish,
one should understand why there is a need for this. All kidneys are pumped, and you can assess the kidney and know how the kidney is working. And one should understand what is the most common reason for the lungs being not accepted. Is it infection? Is it lack of resources or lack of timing, logistics, and why lungs are not being accepted? Having all those put together, then X5O offers a system to assess a lung, otherwise would not have been would automatically be rejected, either because of there is no surgeon there, or the organ cannot be transported in a timely manner, or it was a contusion not improving, or it was an infection or a clot or something that you would have not automatically rejected the lung, but it offers you an opportunity to explore the possibility maybe it will work. And a lot of therapeutics can be done to improve the lung. And in the initial trial that was done, DCD lungs were included. And when you have a circulatory arrest in your donor, it gives you a good opportunity to assess the lungs, and you're more comfortable taking the lungs. Having said that, in a DCD, at least in many centers, within the first hour of withdrawing support, if the donor passes away, you just go to transplant. There is no need for any ex vivo system. But if it goes beyond an hour, then you may want to use the system. So if you are expanding the donor pool by including DCD lungs, Hep C lungs, where you want to offer therapies, then it gives you an opportunity to evaluate every potential. Costs are real, and mitigating costs is a challenge unless there is a commitment from some other entity to neutralize the costs. That's a challenge. If the lung is going to look good, you can know within the first hour. If the lung is not going to look good, it's not going to look good after the first hour. Number one. Number two, it continues to get better as you keep running it. That's a good sign. And normothermic, 32 degrees is always good. And mitochondria are working. And you again cool it down before you do the transplant. Another advantage on our new trends is the lung guard, which is another system where you transport a lung at 10 degrees or 8 degrees temperature instead of a cooler. If you cool any live tissue to 0 degrees, the mitochondria stops working. And when the mitochondria stops working, your cell will not come back when you reperfuse within a short time frame. That's why we put the longest ischemic time to be 6 to 8 hours. But if you keep a lung at 4 to 8 degrees, your mitochondria are working and you can extend your ischemic time. So people have used, instead of throwing it in an ice box, keep the temperature at 4 to 8, extend the ischemic time, and the logistics of how to transport, whether if someone is available to transplant, all these have been addressed by just changing the temperature. And the newer trend is add positive pressure, PEEP of pressure of 15 centimeters, and the lung is open instead of collapsed. A open lung is it has alveolar architecture, and the interstitium is open, and you can keep the lung for a longer time and transport from further distances. And those ischemic times can be extended beyond 12, 14 hours. That doesn't address one need where there is a marginal lung, and will it get better because you're maintaining at 410? No, there is no guarantee for that. So this system has a role where you're trying to expand the pool and you're assessing marginal lungs, and you really want to transplant more patients, and this system has a role.
Any more questions? Will, anything you'd like to add?
I think Steen solution, the cost for our country, it may be propagable, but obviously if some Indian company in the future will, comes forward for this can be doable. So because it's mostly albumin with dextra, and those things are very cheap in India. So if that is achieved, I think there may be a better usage for this. Or you have one center, it can be used by many programs. So they can run a service for ex vivo reconditioning and prolonging ischemic time at the same time.
One very other important observation is with the manual EVLP, we need a very strong perfusion team. I think one of the strengths of our program is we have excellent perfusion team who takes care of many of these challenges, especially when you're doing manual EVLP, because maintaining LA pressure and making sure that you do not have air getting into the system, priming it properly, allowing air bubbles to escape are all very crucial elements to the program. So I think while the XPS machine does its own thing, once you put the lung on the platform, I think a manual EVLP is much more labor intensive, needs a lot of manpower. So and
For the level of the reservoir as well, drain the.
So Sunil heads the EVLP program for us.
Hello, sir. So usually we start at the level of the lung. So we keep monitoring the PA pressures and LA pressures. LA pressures between 3 to 5 is acceptable, and wherein PA pressure is about 15 to 20 we are accepting. So if LA pressure is coming down, we go up with the height of a reservoir, so which balances. At the same time, it's with the PA pressures also. So it's basically the height difference between a lung and reservoir. Constantly, in the sense, it depends, sir. Like if a lung has got some leakage. So priming volume, we start with a 2 liters. So we also keep monitoring and marking every 1 hour, like how much ml is the loss. And also we follow up with the weight of the lung also. So we correlate both the things. If it's required, we add. Otherwise, we'll mark down how much we are losing. And also these results at the end of X-ray and bronch, these things will give a details whether we are losing the volume or gaining. It's not about level of the reservoir or volume of the reservoir, sir. It's about the pressure.
The height is just to maintain the PA pressure.
More than 5, then we'll just bring down the reservoir height. So we increase the negative pressure in the sense like a drainage with the gravity. Yeah, yeah. Yeah. Yes, sir. Yes, sir. And sometimes because of this negative pressure also, we do observe there is a air logs coming in. So I mean this in the last experiment only we also got to know that if at all negative pressure comes and there is a air logs, what we need to do is just take the reservoir above the lung level and then get the LA pressure up to 9, so that you are going to create some positive pressure to just remove that air logs and then again bring it back to the lung level.
Whereas the XPS or manual EVLP is a closed LA. The function of that is that it maintains pulmonary venous pressure. And that's good for the health of the air cell or the alveoli. So it's very important that a closed LA system works much better. Yeah, so if nobody is taking the heart, then I think it's very easy. If someone's taking the heart, obviously it's a challenge. But you have a flexible LA cuff and you have a stiff LA cuff. So depending upon the surgeon's choice, you can decide, and you can probably trim the edges of that cone to suit the dimension of the LA. You can always use pericardium as an augmentation for all of this, because you have enough of donor pericardium. So that's another thing. But the fact of the matter is, I think the team needs to be fairly well experienced, and they should have rehearsed the step a certain set of number of times for them to make sure that they keep the warm ischemia time as low as possible. Also, once you put the organ on the platform, if you have had an imperfect suturing technique, then I think you will have subsequent challenges with air locks and things like that, and improper perfusion, which can eventually end up with graft loss. So I guess rehearsing this is very important. So it's a very labor intensive, time consuming, repetitive kind of process. So with multiple iterations, you probably will get there. But it's not like a single 1 point fix that we know what to do and we can fix the challenge. Yeah. I think we flush it.
Just flush with perfect.
Yeah, we flush it. Once on the bench. Yeah.
On the back one, we flush with perfect. Then you bring it. The reverse is also with perfect.
Yes, after connecting the LA cannula, we can do that. Retrograde flush with through the LA cannula, we can just do the retrograde flushing also. Yes, yes. So that fills the lung also. Yes, yes, yes. Yes, with a perfect X.
Yeah, we'll flush with, yeah.
Keep it perfect.
3 liters roughly if you need a 4 hour run.
If you are asking about a lung, it holds about a 6 to 700 ml.
Yeah. 3 liters at least for one 4 hour run. 2 liters to begin with, and probably 250 every hour. But if your lung is incrementally gaining weight, I think you have a problem to begin with. So you might just probably terminate the experiment at some point in time. No, it's gone into the interstitial and the alveolar spaces. Yeah. Then it won't. Yeah. You'll just continuously lose volume into the lung. The lung will keep getting heavier. Yes, they'll all start dropping sequentially. So I guess in our setting, if we ever use this platform, I think we must be almost confident that this is a lung that will be usable. Like for example, if you have a contusion and then you put it on an EVLP, there's a chance that that contusion might probably be such an injury that your lung will continue to get wet and wetter. In which case you'll have graft loss, and then you've terminated the experiment. So selecting your patients is very important. And I think also in our setting right now, extending logistics is probably the most reasonable option to have when you want to treat this. Probably you have some atelectasis, you have a boggy lung, you're fairly sure there's no infection, I think you know for sure that you might utilize this organ. And if you follow a carefully calibrated protocol, I think you should probably end up using that lung. But it is a risk for sure. So the expansion, I mean, if you look at the first set of trials that Toronto conducted, I think they did a control of 110 or 120 patients who underwent the cold storage, standard cold storage, versus 23 lungs that were taken through the EVLP platform. They used 20 of them, they discarded 3 of them. So that was nearly 80%. And even with the Inspire trial and then subsequent the Expand trial for OCS happened, in both of them, I think they had very tight selection criteria. So they basically wanted to prove non-inferiority to standard cold storage. So obviously all lungs were standard, and it was only moving it from point A to point B in preserving its function was primarily their goal. I think they achieved those endpoints. While, like Vijay suggested a little earlier, there hasn't been much of a difference with as far as PGD is concerned, but hospital stays with marginal donor lungs, outcomes, ICU stays, 1 year survival, almost everything has been comparable to standard cold stored lungs. So thereby, if you actually extrapolate, you have a 20% expansion to the donor pool, which is a significant number.
More than that, almost 30%
Yeah,
expansion.
almost maybe.
I think the corollary to this is that, till the EVLP begins in India, I mean, the take-home message would be that, focus more on the donor lung management optimization. The OPOs should be in such a way that, we get enough time for donor assessment. We do optimization of the donors well, because that is a basic step. Obviously, as sir mentioned, the cost is the most important limiting factor as far as the Indian settings are concerned. I think in the couple of years future also that also would be solved. But I think the basics is that have a strong team where you can do a proper donor management, and also the intensivists across the country should be sensitized for a standardized donor management, because we see a lot of variations across the ICUs. So I think that's the basic message which should go across.
So if I may add to that, Urmil, I mean, there's a phrase that I remember: if wishes were horses, then men would ride. So the challenge with that, and we've had enough of experience with that in this country. I think OPOs changing their attitude, donor hospitals modifying to maximize organ donation or utilization is something which will probably happen in the next 3 or 4 decades. It's not something that the government really has a directive or a plan to implement, especially in a healthcare system which is 80% or 90% private driven. So I think we are not going to get there. In my honest admission, I think we have to look at methods and ways of trying to improve our retrieval rate with organs, and every single implement that we have at hand, we might probably be able to best adapt and utilize them rather than hope that the government will do things
Yeah,
for
so
us.
I mean, no doubt. I mean, EVLP definitely is going to be a game changer, and as we see more of extended criteria donors more in India, I mean, definitely that's a better tool. But I mean, the only thing is the onus wouldn't be only on the government. I think if the transplant teams and the OPOs, I mean, it's a very, very tough solution. So, but yeah, I mean, even costs. So yeah, I mean,
At least if there is no concerted effort by the medical professional, the OPOs may change their attitude and force you to use OCS and go with their flow of work. If you want to take it, you can put it on your ex vivo and see if you want to do it or not. But we're going to war at 12 midnight. Bye bye.
Is if I ask for an organ in Hyderabad and the donor is from Nagpur, the allocation has happened through NATO. And if I bring that lung here and I put it on EVLP and I don't want to use it, God help that recipient. Because NATO will tell me, why didn't you use this organ? Because the people sitting up there who have framed policy or running organ allocation have no clue about how this system works. They have no idea at all. For them, first come, first serve, senior most on the wait list, O positive to O, A to A, B to B, and so on and so forth. So they're still in that very vintage kind of allocation paradigm that probably I really wonder how it would change, because the only challenge that we will see is to heart and lung recipients. While livers will be automatically utilized locally, probably within the same district, every city has 10 liver transplant centers, every city has 10 kidney transplant centers. So the challenge is going to be largely for hearts and lungs. For us to be able to mobilize organs for recipients far away from the site of donation is never going to be easy. So the only solution is to have a network which will probably allow you to work across your network. So
Yeah.
isolated hospitals will always be challenged.
So creating those networks, emphasizing standard of care, both pre-OR, pre-donor OR, intra-donor OR, and having realistic informatics systems where people are loading actual information, so there is minimal human error interpretation of the data. All those things can address some of the challenges. But I think the medical teams have to take the lead to direct uh, and OPOs.
Transplantation, I think the better it will get. Rather than expect, individual
Right,
practitioners,
right.
the more people get into lung transplantation, I think the better will be the quality of organ management, the better will be utilization.
Also, I think
At least
we have the Indian Society of Heart and Lung Transplant. So I mean, where if the society takes, I mean, it's a dream. Obviously, it's not something which is practical.
we don't have many pulmonologists on
Yes,
it.
yes. But if the
We don't
society
have any cardiologists on it.
like how we have ISHLT, which is a strong body, I mean, if the Indian society reaches to
Yes.
at least 50% of what the ISHLT has been doing it, definitely it will be a long way to go. We do not even have a LS scoring system. So right now it's still first come first basis and the and the criticality of the recipient. So I think there are a lot many changes which probably, as Darish mentioned, maybe the teams together, the society together, they can do it. It's a dream, but
I think one area where this may speed up things is that the law of the DCD is almost done. Some DCD is going to come. So already Maharashtra has start put the law. Tamil Nadu probably in this year, next year it will come. Once DCD comes, maybe there's a more of a role for this.
I'll
But
tell you,
still,
there are
shock
many
for
social barriers to DCD in this country.
See,
Many
brain death
social
was like
barriers.
that 10 years ago. So I still hope it may improve.
But if you look at controlled DCD and withdrawal of support and waiting for agonal time, I think the way that consenting happens in this country, the way that a distant uncle can just come and do away with the wishes of the donor family, which happens very frequently in our country, I think it's a recipe for a lot of trouble. Quite frankly, I hope I'm proved wrong, but I don't think DCD is a solution in our country, at least for lungs and hearts.
No, but if there is a law,
Social,
if there is a
law doesn't work for DBD. Tell me how many hospitals, everyone is mandated to declare brain death. How many? Liver transplantation lives and thrives on live donation. In this country, 85% of liver transplantation is live. 85% of liver transplant physicians and surgeons are happier doing live. They're in control of many things. They're in control of the donor. They're in the control of the recipient. And deceased organ donation in this country is only probably something that we can hope and wish will continue to expand, because it is our it's our bread and butter. No, that's you're seeing a small number. You're seeing a small fraction of the number of liver transplants in this country. 85% is live. And you can ask our Medanta boys, 28 out of 28 are live in Medanta. And so it is in Delhi. That's what I'm saying. So, and And the unfortunate part, yeah, that's because they have a in-house team, and generally the heart lung comes from outside. Teams come from outside. So that's the sad part where we are completely reverse of what happens in the Western world. Well, I'm not saying that that is the great way, but I think probably that is a more ethical and sensible usage of organs, yeah, organ utilization rather than a live source. Yeah. Yeah, it's tough. But I think we must. I think we must strive because we will get there. Eventually, we will get there. I don't think there is any reason for any one of us to be despondent. I think we must strive because everyone in this room, probably, if you look at the average age, is less than 35. Most of you. So when you're looking at that, I think we are looking at a new emerging science in this country, and I think that's the great part about lung transplantation. Yeah.
We'll stop here and move to the other slide. Thank you.
On the left side of the dais, we have put a few workstations, which includes a mannequin of pig lung for interventional pulmo and few cannulas for ECMO and ECP, that is extracorporeal photopheresis machine. And on 14th floor, we have our rehab area where delegates can visit and put their hands on. Thank you. And do collect your certificates from the registration deck.